Good morning, everybody, and welcome to today's Adult and Community Wellbeing Scrutiny Committee. Happy New Year to you all, as we perhaps haven't all met since the festive season. Before we begin, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave through the council chamber at the rear doors through reception and assemble in the car park. On that note, I'll then like to welcome Councillor Wendy Burkett, Executive Councillor for Adult Care and Public Health. Welcome, Wendy. And also I'd like to welcome Martin Samuels, our Executive Director of Adults. So welcome, Martin. Derek Ward, Director of Public Health, welcome as well. And then we've got Pam, Alina and Rachel that will introduce you as we hit those agenda items. So apologies, please.
Thank you, Chairman. So we've received apologies from Councillor Parkin, and Councillor Kelly will be replacing Councillor Lee.
Excellent, thank you. Declarations of members' interests. If any member finds that there's an interest along the way, please let us know. Other than that, there will be those that are stated in the interest records. Minutes. To confirm a correct record, the minutes of the meeting on the 29th of November 2023. The minutes are found on page 5 to 9 of the agenda pack. Are we in favour of the minutes? If so, can I have a proposer? Councillor Michael Clark. And second...
Chairman, I think there might be a typo on page 5.
Right.
Item 41. The date shown is 2022. Should that not be 23?
Wait, page 5.
Yes, at the bottom.
Yeah, well, could be actually, technically, if we're doing the minutes for the 29th, then, oh, that was the 2022. Yeah.
The date of the meeting's the wrong date. That's correct.
That's fine. Okay, everything else all right? You happy to propose? Seconder? Councillor Rob Kendrick. All in favour? Excellent, thank you. Any abstentions or against? No, thank you. Chairman's announcements. I'd like to remind members of the committee that there is the Technology-Enabled Prevention and Care engagement event, otherwise known as TPAC, which is beginning at 1 p.m. in committee room 4, which we can drop in after this meeting if you are still about. I appreciate that some of you have got to leave early. But anyone that can stay on, please do so. Thank you. Executive Councillors, Wendy?
Yeah, just like to thank all of our staff that work in the hospitals over the last few weeks. With the junior doctors' strike, it has been very, very difficult in the hospitals, and they have worked above and beyond to keep our residents moving out of hospital as quickly as possible when they've found themselves there. So just a big thanks to Andrea and her teams, both for Pilgrim and Lincoln. Thank you.
Excellent, thank you. So, Martin, I'd like to...
Thank you, Chair. So you'd asked me previously to give the committee a brief update on the Wellbeing Service following the consideration of that service at the Executive recently. Clearly, you'll be aware that the Executive took into account in their conversations and debate the comments that this committee had made on the draft paper. That in the course of the conversation, there were points raised about how certain we were about the number of people who would be accessing the service, and seeking some further details about the eligibility criteria, but that subject to those being addressed, the Executive were content to delegate the the decision on recommissioning of that service to me, advised by Councillor Boquet. We have done some further work now on the demand mapping, and that is going to be considered through informal routes. But essentially, we've been able to do the analysis that we are confident that the changes to the eligibility criteria will allow us to maintain the number of people who are accessing the service and able to go through and receive the service within the bounds of the scope that we have the funding for, and therefore the capacity of the service. We've done significant work on developing the eligibility criteria so that we have a clear set of eligibility criteria that we think will focus the service on the people who could really benefit from it. And we've designed those eligibility criteria in a way that we can ratchet up or down the entry threshold so that should we find that there is more demand than we expect and we have capacity for, we can ratchet up those eligibility criteria to make sure that we are addressing the highest level of demand within the capacity we have. Or alternatively, if we were to find that that we have less demand than we had thought, we can ratchet the eligibility criteria down slightly so that we can make sure that there's a match between eligibility and the capacity of the system. So we always run the system full, but that we are making sure that it's always addressing the needs of the highest priority people. So that's just going through the process at the moment, and subject to final views from Councillor Boquet and other members of the executive, we are hoping to be able to proceed with the tender process next month.
Excellent, thank you. I did watch the executive. It was quite an interesting debate about the Wellbeing Service, as well as we had an interesting debate on it, and there's a lot of ideas put forward. I mean, one thing in that, and actually I'd be pleased to know the executive did listen to our comments and actually agree with our comments as well, so which were sort of put forward. One of the things actually which comes a bit later in the public health report, it does talk about One New Lincolnshire and how they're striving to basically, in effect, prevent the falls. But one thing on the Wellbeing Service, the falls was also mentioned. It might be that we have sort of like tips. So, for instance, like the One New Lincolnshire has a tip advice before it goes into its classes of training, as in just like simple tips of don't leave clutter all around your house and sort of bits like that, just as sort of what I call well-being tips. Really would be quite a good thing just to try and reduce that number. But no, all in all good. So on that note, we'll move on. So we'll go to item 5, the Adult Care and Community Wellbeing Budget Proposals for 2024 to 2025. So welcome Pam Clipson, Head of Finance for Adult Care and Community Wellbeing. Who's going to start off, Martin or Pam?
Well, shall I just say a couple of words and then Pam can pick up. So we're very conscious that adult social care is a very substantial proportion of the council's budget, and indeed is a steadily increasing proportion of the budget as we see the impact of inflation and the changes to the national living wage, and as we have more people in the county, more older people, and more people with long-term conditions that require that they receive care. So we recognise that that's a strong push. Those issues are felt by every council in the country. What we're particularly trying to do is to make sure that we get the right balance between ensuring that the people who need support and are able to draw on care and support that meets their needs and enables them to live the life that they choose in the community that they want to live in. But at the same time, we need to make sure that is done within the finances that are available to the council. We've recently been involved in some national benchmarking work, which indicates that per head of population, Lincolnshire is one of the lowest spending councils in the whole country. And we've been looking to looking through that data to see, well, does that mean that there is a significant amount of unmet need? And it would appear from that benchmarking data that we are supporting pretty much the same proportion of the population as other councils are, but we're managing to do so at a lower cost per person than is across the position nationally. We are in the bottom quartile in terms of the amount that we pay. And I think what I would flag, and just in a sense as a sort of trailer for Derek's report that comes next, my sense, having come from other councils, is that the reason Lincolnshire is able to do this is because of our very effective preventative work that supports people, enables people to live a healthy life in the community, and therefore postpones the time when they might need to come into the care system. And that's one of the key factors why we're able to spend less. But it is a key thing for us to be looking at, because it would be very easy if we lost control of the flow in, the amount of money that needs to be spent on adult social care could increase significantly, and that could have a big impact on the council more broadly. And that's why it's a particular focus to make sure that we meet the need that people have, but we do everything we can to enable people to avoid having the need in the first place, because living a life where you don't need to come into contact with adult social care is clearly a better life than one where you do. Clearly, people are in different circumstances, but if we can do that earlier work with people in communities, that they maintain health and independence, that has to be a win for everyone. But with that sort of broader context, I'll hand over to Pam.
Thank you, Martin. So here to present the 24-25 budget proposal, which for adult care is 204.6 million net budget, which is shown on the table on page 15 of the report. This is one of the largest increases for adult care Lincolnshire, at 12%, and that is driven predominantly by the two areas that Martin has highlighted. The national living wage that was announced in December was a higher than planned national living wage, even through the forecast for the Low Pay Commission, which is the forecast process that we follow. At £11.44 per hour, that's a 9.8% increase, and that hourly rate is a core component of the unit rates we pay for care, whether that's a residential bed cost per week or our home care community supported living hourly rates. In addition to that, we have or are proposing to increase our unit rates by an additional 3% for the non-pay elements, reflecting the Bank of England's forecast inflation average for 24-25. Those two elements alone equate to £16 million of the £22 million increase between 23-4 and 24-5. So obviously a material figure driven by those two areas. Secondly, we continue to experience growing demand. We've got a 3 to 4% increase across our working age adult services, with our mental health care seeing the higher end of that 4% increase. For the first time since the pandemic, our residential care for 65 years and over has seen a growth in demand from previous self-funders, with 51 more people coming into care at our average cost of £650 per bed per week than we've had since we left the COVID-19 sort of period. Aligned to national policy, and we've seen a increase in people discharged from hospital. We've seen a 16% increase in demand for social care following their inpatient stay, but the cost impact of that is forecast to live within the previously announced discharge funding that has now been confirmed to continue into 24-25. And for this local authority, it was £4.8 million in 23-4, and it's forecast to go up to £8 million in the next year. But that will cover the cost of packages of care, community equipment, and other costs associated with individuals' needs on discharge. There is a smaller increase than we saw this year in the public health grant for 24-25 at £474,000. However, with the demand management and the preventative work going on within that area, public health is continuing to forecast the ability to deliver services within that grant allocation going forward. Adult care and community wellbeing, therefore, for 23-24 is financially forecast for the year end to deliver a £500,000 underspend, And as we've discussed at this committee before, that only equates to half a day of the average spend in adult care for the year. So the risks facing the services as we go forward is that the demand that we see in 24/5 increases further than we've got forecast. So if we go above the 3 to 4% in mental health, that will cause a financial pressure for us. If inflation doesn't fall as forecast by the Bank of England at the moment to that 3%, if it's slower, that will put pressure on our market and therefore the rates that will be proposed through scrutiny and council in the coming weeks. And in the medium term, there is significant uncertainty over the funding base for council's funding, let alone adult social care funding, as we move beyond 24-25. So the improvement programme for adult care and community wellbeing is the key to delivering that continuous improvement and curtailing the spend that we see. As Martin highlighted earlier, the benchmarking does continue to show that we have got the lowest unit cost within adult social care. However, that therefore doesn't leave us a great deal of room to go to. And the continuous work on the strength-based approach to maximising people's independence, building on the synergies that can be achieved with the prevention agenda are therefore key, alongside the continuation of delivering best value and making sure our end-to-end processes are efficient and effective as they can be, remain the priorities for the Directorate going forward. Happy to take any questions.
Okay, thank you very much. So, well, it certainly highlights the financial pressures, that's for sure. And I think looking at it, it's going to be potentially the same next year in terms of I can't see that an election will suddenly radically change in effect. So I suspect it'll be a sort of nearly a roll on again for another year. And our medium-term planning and everything's all aligned now to these new rates and everything's all sort of dovetails together. Questions? Andrew?
Thank you. Well, it's not a question, it's more just to support something that you said, which is that the underspend of £500,000, everybody throws their hands up in the air as soon as you mention we're not spending all our money. But when you say it's only half a day of services, I think that's the important bit. Because if it was the other way, it would still be just half a day of services in deficit. And I think we need to bear that in mind when we're worrying about having an underspend, because it's a drop in the ocean, isn't it? Thank you.
Okay, Marianne?
Thank you. Apologies for being late. Thank you again. Always a really good report, and I always feel that you've got a really good handle on the situation and have taken action on the issues that need taking action on before it arrives. So much appreciated. The question is about actually getting the service to fulfil the funding. I'm particularly concerned about care, and that obviously, as you said, is an increasing need for people with care. But are we going to be able to get the carers? Because if we are low per unit, it's going to attract people from far and wide across the country to think, oh, they can get care in Lincolnshire, it's cheaper. And I just wonder if we're going to find that, I didn't mean that to sound bad. I just mean that it's something we might need to deal with. We just at planning last night, another new home series of homes for people, 47 homes needing care, was passed. And I think this is maybe a growing thing that we're going to see in Lincolnshire, and we're going to have to find people to actually do the work. Because if all those people moving in are required to have at least 2 hours care before, in order to move into that home, then it's going to be, it adds a lot of pressure on actually being able to find people to do the work. So it's good having the budget clear, but is one of the limiting factors actually getting people to do the work? Is that one of the reasons why we're in cost? Thank you.
Yeah, I mean, just on that, somewhere else in this report, it does talk about, not in this budget agenda, but it does talk about the recruitment exercise, the extra funding that was added to their wage. And although we have got additional pressures by the fact that it's the wage has in effect gone up by nearly 9%, that is in effect a good thing, because in effect it's lifting that sort of the carer's wage up. So as much as it causes us issues in terms of budgeting, but actually from a point of view of trying to keep staff and attract staff into the industry, it's a good thing. Martin?
So if I can start, and it's Alina is right behind me, so I can't see whether she's gesticulating, but I might I might call her in a second. So you make it's a very good question. A couple of things. I would draw a sharp distinction between the rates that we pay as a council for people who are the responsibility of Lincolnshire County Council, but a sharp distinction between those rates and the rates that people who are self-funders pay. So if for the sake of argument, if there was a family living in Surrey and they thought, oh, we'd like to come to Lincolnshire, it's a very nice county, they wouldn't have access to the rates that Lincolnshire County Council pays, because if you're a Surrey resident, then you are the responsibility of Surrey, and then Surrey would need to pay whatever the rates that they were paying. Well, normally you wouldn't farm people off to a far end of the country. If you choose to move, if you as an individual choose to move, then it's sort of your choice as to where you go. Now it can happen that someone says, well, I'm starting to have care needs, and I might need to move, but we don't tend to find much, as it were, care tourism. So these are the county council's rates. People who move and choose to pay for themselves, often the rates that self-funders pay are very significantly higher. I mean, nationally, there's normally about a 40% variation between what a council would pay and what an individual would pay, and that's sometimes reflected in the quality of what people get. That if you pay more for a care home, you might get the nicer view, the bigger room, that kind of thing. But I think it's I don't think we're in a position where the rates that we pay are likely to draw people in from elsewhere. In terms of workforce, we're doing a lot of work with Linca, the Lincolnshire Care Association. Generally, we're not finding it too difficult to get care placements at the moment. There are a large number of care homes across the county. We have no significant difficulty in placing people at rates that the council is prepared to pay. In terms of home care, again, we don't have particular difficulties. There are always issues at certain times of year in terms of getting sufficient workforce. We are doing work both to make social care an attractive career for local people. We're also involved in the national programme of international recruitment and making sure that we are making available good jobs that are appropriate for people to come from overseas to do, and making sure that we're supporting people who choose to do that. But overall, at the moment, we're in a fairly good position. But I'll ask Alina if she wants to come in and sort of add a bit to that, or indeed if I've got some of that wrong.
Thanks, Martin. Just one little bit I wanted to add, because I think this is really reassuring and it will come out in the presentation later. Workforce is a challenge across the country, and that was really borne out through the state of care through CQC. But Lincolnshire's bucking the trend a little bit around that. So in terms of the data, in terms of staff vacancies across the sector, this time last year it was a 19%. We've got a reduction down to 12%. That's the opposite to most places around the country. They're seeing more and more staff vacancies. So I just really want to compliment what Martin said. Just we're seeing the difference in the data, and that's partly for what Martin said around all these initiatives that are being deployed. It's bearing some fruit. Staff retention still an issue, but overall staff vacancy numbers have reduced by 7%.
Okay. Mike and then Tracy.
Thank you, Chairman. It's item 5 on the capital programme. I know we've made some moves there and there are future investments, but if we're going to try and, as it were, save money in one area, should we not in the future be thinking of making even more investment in the opportunities we've got for care in a sheltered accommodation type facility? Thank you.
I think that's one for you, Martin.
Yeah, so I'm happy to pick that up. One of the things I'm wanting to do is, now that I've arrived in Lincolnshire, is for us to refresh our supported living strategy so that we're really clear, drawing on data that Derek and his team have developed in terms of what the population of Lincolnshire looks like now and will look like over the next number of years, and our understanding of what the needs will be, so that we can have a real sense of how many people might need supported living, and I sort of draw extra care as being one of a number of different options within that. How many people might there be? Where across the county might they be located? And what sorts of age groups and needs might there be, so that we can be really clear on what the need might be, and then we can work with the district councils and others to say, well, how can we ensure that those needs are most effectively met? So there are a number of schemes in hand to expand that sort of capacity. We have to be really clear that we get that balance between demand and need right. I have unfortunate experience in other authorities where we've got that wrong, and we've had facilities that were not financially viable. And, you know, we built them and then they weren't financially viable because we got the calculations wrong. So I think it's very important that we do that very carefully. But I think this is a clear area where there are a lot of people across the county who probably have reached the stage where they can't live entirely independently anymore, but they really don't need home care of the level that we would normally supply, and they certainly don't need to go into a residential home. So that little bit of additional support, but it's that question of making sure that it's a scheme that offers people a life that they want, that they would choose, and also that it's financially viable. So I think there's a lot more that we can and will be doing, but we need to progress with a degree of caution, that we don't want to invest a large amount of capital in schemes that then actually we can't make financially viable. We might be able to fill them, but they might not be financially viable.
Thank you for that.
Wendy?
Yeah, it also worries me that our district colleagues are actually having all these private extra care facilities popping up all over the county that our residents can't afford. Certainly, I know of 2 or 3 recently, and they're £1,200 a week for this hotel living, and it's just not affordable. So districts do have to work with the county council, and so where we are showing need, that we provide something together that it is affordable for our residents. A real concern to me at the moment.
Thank you. Thank you. Tracy?
Thank you. The risk on the finances is obviously ever increasing at the end of the day. So what concerns me slightly is, it's great that we're working on a strengths base. It's great that we will encourage people to be at home, and I'm all advocate for the longer someone is at home, the better. But benchmarking of cost per spend, have we done benchmarking and case studies of what we would deliver to a person as against to what someone else would? So exactly the same. So this resident comes who has this ailment, that ailment, and they think they should be in a home. What our reaction would be in comparison to another council? Because it worries me that we will be encouraging more and more for someone to stay at home. And are we risking, or could we run the risk that we could be risking people the more times the pressure comes on, basically?
So I can answer that quite straightforwardly. So there are two very powerful ways that we do that. The first is, that's one of the key roles of my principal social worker, Chris Erskine, is to work with other principal social workers across the region. So there's that clear sense of, well, this is the decision-making process that we have in Lincolnshire. What's the decision-making processes that you have in other authorities? And you know, are we broadly on a level? And one of the ways that we facilitate that work is that for a number of years now, there's been a peer review process across the region, where each one of the directors in turn will lead a review of another authority supported by their principal social worker, and will do that critical friend process of looking at what that authority does. There's a very intense case file audit process as part of that, where staff from several different authorities will look at case files from this particular authority and that if there are differences in decision making or differences in thresholds, that sort of thing comes out very readily. As it happens, I will shortly be leading the peer review of Derbyshire. I'm trying to remember now which director it is who'll be doing us. We had the director from Northamptonshire came roughly this time last year to do a review of us. So we have that peer review process, and that links with the ongoing work that the principal social workers do. And now the additional process that we have is that the Care Quality Commission, the CQC, they are doing external assessments, I think is the current term, doing external assessments of councils. Obviously, we were the first in the country to have that. Excuse me, that involves looking at case files and making an assessment of are the thresholds appropriate. So I think we've got quite a robust process where we are checking at individual person level to see actually, you know, if with this individual would this person get a different response in different parts of the region, so that we can be clear that we're not off on a limb somewhere.
So yeah, but on that note, you're going to Derbyshire, and if I recall right, Derbyshire has a phenomenal extra care housing strategy, or it did have. It aimed to have something like one within 12 kilometres of anybody. So, and I know they invested heavily into it, so it'd be worth just seeing what their extra care housing situation is with an update on having done all that work. They did it quite a few years ago. Tracy?
Thank you. When someone next comes to our council and does those case studies, could we as a committee kind of get an update on that? Because I'll be honest, I've got a good memory and I don't remember ever having that before. So that would be really interesting if that's possible.
So the peer, I mean, obviously the CQC report is in the public domain and indeed is attached to one of the items on the agenda today. The peer review processes, that always leads to a letter from the lead director to the receiving director, and those are always published as well. So my expectation is that that would come to this committee for you to have a debate about it. So yes, the next peer review has been planned. I just haven't in my head got the date, but I think it is later during the course of this calendar year.
I think peer reviews also tend to go to the audit committee, don't they? I think, is there I know, don't know. Have a look. So, what's... hi, Nikki. Yeah.
Thank you for the report. This is really a question, I suppose, an observation of all the detail that you've put in there, and there's maybe can be answered by Derek and by you, Martin. My concern is that we have an ageing population. There's a lot of rurality where access to GPs, access to healthcare is difficult, and it's going to become even more difficult. People traditionally do come to Lincolnshire to retire, so we're going to have an increasing ageing population. I just want to ask you, how sure are we that our GPs are promoting healthy ageing, healthy living? How sure, because that's going to help reduce the burden on the healthcare systems all the way around. So, you know, how sure are we that they are doing everything they can to promote healthy ageing, so that, because you talk about the move thing on page 47, which is great, but actually when I go into my doctor's surgery, and it's very good, actually, the support I get there, but there's not much in the way of healthy ageing, healthy living, and I think that doctors are still stuck in that, we prescribe it and get you on your way, prescribe it and get you on your way, not actually taking the time and the patience that people are really going to need as they get older about how they can live more healthily and more independently. Thank you.
Well, a lot of that comes on to the next agenda item, but Derek,
thank you.
As well go for it now.
I'll be quite direct. I think I'm sure that they aren't, but I'm not sure that they should be. So just to hedge my bets there, you know, a GP, a doctor has gone through a very long training program. very expensive training program, and our NHS and our clinical care are some of the best in the world. That comes out in the benchmarks. The question about how we keep people fit and healthy when they've got existing conditions, how we make sure that they live the best life they can with those conditions and wrap support around. The Chair, Councillor Marfleet, already mentioned One New Lincolnshire, which is one of the programmes that we've put in place. And it's not just about stopping people getting sick in the first place, it's helping people who've got existing conditions increase their physical activity, reduce their weight through diet and nutrition, stop smoking, all of which is going to help people, for example, who've got cardiovascular disease or who've got asthma and breathing difficulties. And clearly, if you've got a highly trained physical activity support person, they're probably going to cost 1/5 of what a GP would cost, which means they can put in 5 times the amount of time that a GP would, and they're going to get a better outcome in that. So it's a really good question, how we support people to stay fit and healthy, whether they are disease-free or whether they've got existing conditions, is, I think, a key challenge for us over the next few years. It's a national debate, and actually it's a global debate, certainly in the established market economies, and I think it will play through. For us, I think we're ahead of the game on this because of things like One New Lincolnshire, with the work we're doing on balance and stability programs and falls prevention. We've got a range of different programs, but given the financial challenges we're seeing, we've got to work really closely with our NHS colleagues to try to see where we can free up some of the money we're spending dealing with problems to try to stop those problems in the first place, and those conversations are ongoing.
I mean, actually, you raised a very good point there, really, and it's, I agree. I mean, should the doctor be that place? And I think actually that's perhaps something that needs sorting out as we go forward, because I think everybody just thinks that is the potential place, and as you say, our wellbeing service is a good brand, and it's perhaps that needs to be the go-to, doesn't it, for the whole active ageing. But Andrew.
A quick question. We mentioned the extra care housing and the budget this year of 12 million, 7 million allocated. It's just the extra 5 million. Where we are with that? Thank you.
So they'll go through the usual process, so aligned to the new strategy, where's the best investment, how do we best invest that funding, will need to be driven by business cases through the usual governance process of Adult Care's DLT, and then into scrutiny in the executive, depending on what the proposals are that come from that. So it remains within Adult Care's ring-fenced capital funding, but how we decide to spend that will be aligned to the refresh, as Martin indicated earlier, of the needs across Lincolnshire and how best to meet them.
Are we expecting to spend that money in this next year, that 5 million?
You won't spend it in this year. It doesn't disappear. So capital we do carry forward. But given you've got to decide what it is, put it through the governance, and actually spend or build, or depending on what it is, it won't be spent in this 24-25, but you won't lose it.
No.
Welton obviously is undergoing at the moment. It's really coming on really well at the moment, which is our extra care. Was this, I think it's 70 to 71, I think, somewhere like that. Apartments in Welton, and then NK will be starting there. North Stephen, we're going the Hoplands there. We're joining with those with the extra care and the working age adults. That will be starting, I believe, at the end of the year. So that's 2 that's coming along, and then obviously we're going to look at to the rest where because we did want to go to Horncastle, but just looking at that at the moment.
Thank you.
Yeah, it's something that wants to keep pushing on. Okay, no further questions. I think what we can say is any comments back to the executive that we in effect support. I would say the budget. I think there is concerns at the level that it's increased by. If you read the next report, there's even more concerns on the percentage of people drifting into the elderly age bracket and category. And in essence, I think really the focus is on the preventative services to try and keep people active and healthier for longer, and staying independent without a doubt is a primary key focus and areas to keep developing. And then the next area is the transformation of adults within itself to ensure efficiencies within the system, of which we've asked for an update for later in the year, June time, on the sort of around the transformation of adult social care services, for an update on that one. So, and as the report mentions about community-based infrastructures and community-based support, on that note, we will, unless anybody's got anything else to add, I'll go for a proposer and a seconder on the budget. Proposed Tracy, seconded Marianne. Any final things for the exec? We're happy with what's just been said? Yeah. Okay, so all in favour? Excellent. I think that's unanimous, so thank you very much. On that, thank you, Pam. And on the fact that we now are getting very community-based focus, that will take us nicely into Derek's annual public health report.
Thank you, Chair. As everybody knows, this is a statutory responsibility on the Director of Public Health to produce, statutory responsibility on the Council to publish, and as ever, try to bring it through a whole range of different boards and groups for comment before we get to that final point. What I'll do is I'll pull out sort of the high-level summary, because I'll assume everybody's had a chance to have a look through to give us more time for discussion, if that's okay, and we've already started that discussion. So I'll just introduce the report, if you like. What we've used this year is we focused on the ageing population with a very specific focus, and maybe just to put in context some of the conversation we just had. The fact that we've got an ageing population is a good thing, because people aren't dying young. Obviously, there are some people who still die young, and we focus on those individuals. But what we've done as a system is we've introduced a whole range of different interventions, some of them medical, some of them national political and policy, that have helped people live longer. So that's a good thing. One of the challenges that brings is because and as people live longer, they are more likely to develop diseases that are associated with aging, and as we've seen, people tend to develop multiple conditions, and we've got a health and care system that's still very much based on people with one condition at a certain age, and there's no doubt in my mind, and I think probably Scrutiny's mind, that we need to develop our health and care system to catch up with the changes we're seeing in our population. So the report really focuses on that, and it also focuses on a framework to do that, which is the Age-Friendly Communities framework that's come out of the World Health Organization and is part of our core work as a Centre for Ageing Better rural partner nationally. So that's the frame for the report. A little bit of background, as you'll have seen in the report, our population is ageing. Over a 65 population in Lincolnshire is projected to increase by over 40% by 2043, so over the next 20 years, and our over 85% population is going to nearly double over that period. Again, that's a good news story in terms of people who live in longer. What we've got to do, and the title of the report flags this up, is as well as adding years to life, we have to add life to years. We have to help people to live longer, healthier lives, or at least manage their conditions better, and the report goes into that. The ageing population is not equally distributed across our county. You'll remember from last year's report that we have a large rural, coastal, dispersed population. That brings with it challenges in terms of service provision, and the report demonstrates that our ageing population, where our population is, and the deprivation creates a complex picture across Lincolnshire, and our health and care services need to recognise that in terms of the services that they provide. One of the key questions we seek to address is, are we ageing well? So life expectancy and healthy life expectancy are really important. We can add years to your life, but if those years are lived in really difficult situations with lots of complex diseases, then that's not a good life. And we need to focus on that. If somebody survives till they're 65 in Lincolnshire, if they're a male, their healthy life expectancy is another 10 years, and their overall life expectancy is 18 years, 18 and a half years. So about half and half in terms of another 10 years in a healthy life, and then another 8 to 9 years where they've got multiple conditions. And what we need to do is maintain that getting on for 20 years, but shift it so that more of those years are healthy, either disease-free or minimising the impact of diseases. For women, it is over 20 years is the life expectancy, but the healthy component is similar to men. It's just that men tend to die younger once you get to 65. So women are living longer in an unhealthy situation, and we need to address that. And there's plenty that we can do to address that. So I think one of the things I really want to get across to scrutiny is, in Lincolnshire, we're doing a lot of work in this space. You've been very supportive of that work that we've been doing. We need to keep doing that. We need to really increase the amount that we do in that space. And to do that, we need to work very closely with our NHS partners. We know that there are going to be challenging needs across the population over the next 10 to 15 years. And these are needs, not just demands, as Martin was talking about earlier. Because of that ageing population, the number of people expected to have a fall will increase by more than a third over the next 20 years. So we need to intervene earlier to make sure that people understand what the risks of a fall are. We need to intervene earlier so that we help people maintain their balance, maintain their muscle mass, so they're less likely to fall. And if they have had a fall, we need to intervene earlier with a balance and stability program that shows them how to avoid falling, how to stand up and sit down safely. And if they do have a fall, how to fall in a way that's less likely to injure themselves, and how they can get back up off the floor. There's a whole range of evidence that we can use there, and we are piloting a program in that area. Scrutiny are aware. As we get an older population, we're going to see more people with multiple conditions. We know that as well. And one of those conditions is going to be dementia. We're going to see an increase in dementia. But again, even with something like dementia, it is not inevitable. There's a whole range of things that we can do to reduce the risk of dementia, and to ensure that people who do have dementia are diagnosed early and treated well, and minimise the progression of the disease. So in a few fora where we've presented this report, it's come across as a negative report. I don't see it that way. I see this as fundamentally a positive, in that we are helping people live longer. What we need to do, and we know how to do, is help them live longer, healthier lives. The way that we've broken it down, and I won't go through each of these components, but I'm happy to pick up any, is we've used the age-friendly communities framework and the petals on the flower to describe what we're doing in Lincolnshire and where the population's going. So they may be around community support and health services, respect and social inclusion, communication and information. And we've got all of that in the report. I won't go through those, but happy to pick up. But the interrelationship between all of those flowers and the petal is really important. We can't take any in isolation. It is all part of the whole flower. And in Lincolnshire, we need to look at it that way. It's a system approach. And you'll see that a number of the components that we've talked about are things like transport links, are issues around connectivity, whether it's connectivity to the internet so that we can deliver services differently and connect people up differently, or whether it's connectivity between individuals with their families, with their wider communities. That's going to be key. We've talked before in Scrutiny about making sure that somebody leads the best life they can. Really is about people having a home, a job and a friend. Now, as people get older, it may not be a paid employment job, although we need to make sure we keep people in paid employment for as long as they want to be in paid employment. But it might be opening up opportunities to volunteer or civic engagement. That's going to be really important for the population of Lincolnshire as we age. And the interconnectedness between all of those components is really important. And you'll see there, coming back to our previous conversation, housing is a key component there, and our work with districts in that space is going to be really important. We've put some recommendations, but just to distill those down really, the areas we're focused in specific areas can have the biggest impact in Lincolnshire, in our view, are around social isolation. And there's a whole range of things we can do around that. Are around transport, and we're already doing a huge amount of work in transport. But given this is a large rural, coastal, dispersed community, that's always going to be a challenge for us, so we've got to think differently. Digital inclusion is one of the ways that we can think differently, and as Councillor Marfleet said, we are looking at digital technology to support people and to prevent health and care demands as well. And housing is a recurrent theme throughout. What we want to do with this report is we want to move it into a more detailed state of ageing report that people can use for their planning purposes. You'll remember we have a joint strategic needs assessment, and the more intelligence we can provide to the system around what and where to focus, the better. And we're going to reinvigorate or reinvent our approach and move towards a housing, health and ageing well delivery group that brings together some of the housing and the ageing well components, which will be chaired by Councillor Bokett, to make sure that we bring all of these different partners together, and that will be one of the key mechanisms to deliver some of the recommendations that we've outlined in the report. So that's by way of background. Happy to have a conversation and answer any questions.
Excellent, thank you. Well, I think it's a very good report, Derek. I think you've very well wrapped up the state of Lincolnshire's issues. I wouldn't say necessarily the actual ageing population. You have put all that in, but you've linked in what are some of the major issues to preventing a better ageing population. One thing that you've actually teed it nicely up for is for the new potential mayor of Lincolnshire, because actually a lot of it sits under his remit. So if we decide to opt for a mayor following the consultation exercise, I suggest that you approach each of them and actually give them a copy of your ageing well in Lincolnshire, because it's in effect a lot of it, housing, transport, skills, sits in his new remit or her new remit. But no, it is very good. I suppose in some sense, I went to doing the devolution, sort of looking at that aspect. I went to the Nunsthorpe estate in Grimsby, where it has a community-based hub called Centre 4. And for me, that's what I aspire as a community-led infrastructure. It was an old school. Everything works out from there. The wellbeing service, the providers of the wellbeing service tribe. You've got classes for adults to prevent falls, Tai Chi. You've got cooking. You've got a cafe. People are going to the cafe and meeting up sociably. It is actually the hub of a community, and it really is a real, to go and look around it, walk around it. It's got sports, gym, and everything's sort of based there. And people travel in. It's easy to park. They've even got a farm. They've got animals and everything for the young kids. It really is an amazing centrepiece, actually, and we sometimes look at sort of our neighbours and don't pay enough attention, and sometimes, and I know Derek's toured round and I've spoken to people about the sort of good work that you did, and and it is truly inspirational, some of the work that goes on across our borders without us necessarily knowing about it, and they're still in Lincolnshire. But that, I thought, Centre 4 really was a wonderful way, and perhaps come on to that in a bit through the contracts and how sometimes we are better working together. It's a centre point that everyone can head to, and you can go and have your lunch and also socialise and then do Tai Chi or whatever you want to do, and mobility, movement, social prescribing, all under one house. So on that note... It's Rob, Mark and then Tracy. Right, Rob.
Thanks very much, Chairman. I'm sure Derek won't be surprised to hear that I'm very interested, particularly in Chapter 8, which is combating social isolation. And as you know, I was involved in managing volunteer services in an NHS trust for many years. And one of the schemes that I felt was particularly successful was a one-to-one befriending service for mental health service users. And the benefits I saw from social contact was amazing. And I think non-clinical interventions such as that can be so beneficial because A, they're low cost, and B, they do have a definite positive outcome. And I think if all our colleagues in other services such as the NHS could be encouraged to support those projects, I think it would be a great progress to have, because watching the way people can get into work through it, as you indicate in your report, or gain social contacts is amazing. And I always used to say, despite the advances in mental health care, there's no treatment that cures loneliness. You can't have an anti-loneliness injection or pill, as it were. It's only human contact that deals with that. So I think it's great that this is highlighted, and I hope in your discussions with colleagues in other services that this can be quite high on the agenda, because it is low cost in terms of just having it managed by somebody and recruiting people to do that. And also, of course, in my experience, 40% of the volunteers I had were either former or current service users in the NHS. So again, it was beneficial for people who have health problems of various kinds to be involved in volunteering. So more power to your elbow, Derek, on that one. I think it's brilliant. Thanks.
Okay. Martin.
So if just you've prompted a thought in me, and I think it's this issue of social isolation is incredibly important, and I think it's been reflected in some of the national conversations in the adult social care world about how we engage with people and how we relate to people, and some of the language that we use. And I remember very recently being at a session where someone who had lived experience was saying how it's important that we see things from the right perspective, and so that we often talk about we want someone to engage with their local community, and this person with lived experience was saying, well, I don't really want to engage with the local community. I want to go and be a member of the group that meets in the local park. And that we might talk about someone needing a befriending service, and they were saying, well, I don't want a befriending service, I want to be able to go to the pub with my friends. And so one of the things that we've been trying to do in the adult social care world through the strengths-based approach is to shift things round away from a focus on the services that we offer to people to, well, what is the life that people want to lead? What does a good life look like to an individual person? And how can we make sure that we support them to achieve that? And if it's a service, then we may need a service for it. But very often, actually, people don't need or want a service. They want to be able to live a life. And there are ways that we can work, that we can enable people to live a life through accessing the resources that exist in their communities already. And that's a very different thing. You know, having friends is a very different thing from accessing a befriending service, and not only does it have a greater beneficial impact on the individual, the council doesn't end up paying for it, and so there's a win on every side. And so it's a real trend in adult social care nationally about how can we think about these things in different ways that enable people to have, you know, to live a good life, and that's, you know, and that, therefore adding life to years.
Okay, Mark.
Thanks, Mr. Chairman. My apologies for being late. Something cropped up at home that I had to deal with before I came. Thanks for the report, Derek. I arrived just in time to hear you start. I'm looking at page 31, which gives the sort of life expectancy and average life expectancy as 65, and next to it is the sort of map of deprivation across Lincolnshire, and obviously those areas highlighted in sort of green and yellow are the most deprived areas. And sort of looking at the map, I'm the green and yellow area around Grantham looks like a large part of it is centred on the Earlsfield estate in Grantham, which is in my division. So obviously I have an interest in that. But I want to sort of, if you can sort of maybe explain if there is and I'm guessing there probably is, a link between deprivation levels and those life expectancy figures, because I'm guessing they're averages spread across the whole of the county. But I'm just wondering if you have data that if there is a differential between sort of those areas that are in blue, which are the least deprived. And again, interestingly, I've got a very interesting division because Grantham Barrowby has got some very wealthy villages in Barrowby, Allington, Sedgebrook, which are very much in the dark blue areas. But a good proportion of my divisions would be within that green and yellow. So I'm just interested to sort of explore, and I'm not sure if you got the detail to that level, to possibly explain if, is there a difference? And if there is, what can we do about it? Because obviously a lot of potentially of my residents are potentially dying earlier than perhaps the Lincolnshire average would indicate they should be, and what we can do about it to increase their life expectancy. Thank you, Mr. Chairman.
Thank you, Councillor Whittington. And as you would expect, yes, there's a very significant difference in terms of people who are in particular deprivation groups and both their life expectancy and their healthy life expectancy. The figures vary, but we've got all of that underpinning these graphs, so happy to pull that out and share it with either all the scrutiny or individual members. And that is all on the what was our Lincolnshire Observatory website, which is now a different website, which again I think we've presented at scrutiny before, so I'll share that. We have district level profiles that go down to lower super output area geographies, which will map up onto the boundaries that you're interested in. But the basic fact is, yes, there is a very significant difference between people who were born and live in the most affluent areas, and of course that's a fallacy because it's the individuals that make the area affluent. But if you're in the upper echelons of affluence, then your life expectancy is much longer, anywhere between 8 and 10 years than the least deprived, and your healthy life expectancy is the same sort of figures, 8 to 10 years difference from those who are the least affluent. What we can do about it is really is a systemic issue, because it comes down to housing, it comes down to loneliness, it comes down to individual behaviours and choices, it comes down to the infrastructure and support that we provide. So it's a cross-cutter, which is why we've taken the WHO approach to make sure that we try to cover every aspect. I think from an adult care and community wellbeing perspective, Martin's really summed it up really, really well. What can we do to help people lead a good life? And that's the home, the job and the friend, because having those three things does improve your life expectancy, your healthy life expectancy, and your quality of life. But happy to pick that up in more detail outside, and we'll share the detailed underpinnings, and people can you can go in there and look at it. Yeah.
Thank you. I mean, just on that, it is down to individuals also to take their own responsibility. We can only provide services if people don't pick them up and go with them or actually use them, then we can't enforce it. Tracy?
Thank you, Chairman. Before I say the point I was going to point, I was just going to agree particularly with something that Martin, that you've said about kind of the have a drink, someone to go a drink, or do they need a new friend. Links Digital are a really good example of that. If their poster said, are you digitally excluded? Are you this? Are you that? Or do you want to learn how to pay your bills online? it absolutely attracted someone very differently, and I've had similar conversations with Shine. You know, if it's constantly mental health, it doesn't tune in with someone because someone maybe doesn't know that they have that challenge, but they still might need what's being offered to them. So I think that shift is incredibly important with the contracts guys are sat here as well, with anything that we're going forwards with. I think it's really important to actually get the uptake from changing the approach. Derek, your report. South Holland seems to lack again in that report. I think, do you know what? If I was East Lindsey or if I was North Kay, I'd be over the moon about it. But if I look at that map on page 36, I feel really disappointed because we haven't even got our own colour code. We're bolted back in there with South Kay and with Boston. I've got a generic phrase that just says I've got a range of activities. It's not telling me that you've researched what's really gone on and what's actually being held in South Holland. North Kay, it's kind of getting granular. It's saying about that Evergreen Sleaford running the befriending service. The East Lindsey's going more detail. So I feel extremely disappointed again that actually it's not champion what is going on in South Holland, and actually we're doing a lot. I would love to see the kind of instant thing with One New Lincolnshire. They're doing obviously these falls things. Why are they not approaching the districts? It's a very clicky setup. There's the same ones that they go into in each of the areas to work with, but I'm not seeing that open communication with the districts enough. Obviously, we have housing stock. We have 14 community centres that are all generally older people, all with some vulnerabilities. I think they could be utilised much more by all of these other groups that we essentially commission. So I think that's really, really important. Again, we're doing digital skills. We're working with Links Digital. But actually, I think on page 39, we've got an East Lindsey mention and we've got a North Kay mention, but we don't have a South Holland mention again. But we're doing them. So I guess my first question is, have you got any budget to do any of this with district? And if so, give us a shout. And my other thing is, on page 39, it mentions Links Digital Inclusion Group and that they're working with vulnerable groups. Can you let me know what they're doing in South Holland? It mentions a new carer service on page 42, which I wasn't aware of. It would be good to know more about that. And on page 51, we've got the pilot with, again, a district council to install stair lifts, and then the wheelchair service is coming forwards again. Did we have a chat with South Holland about that pilot? And if not, when might it be rolled out with other district councils? Thank you.
Just before you reply on that, the one thing, just going on to the map on page, was it 34? I'm just looking at it. 36. I mean, I looked at that and I can see where you're coming from. But the reality is, and we actually mentioned it earlier, how do we actually map out all the services, whether they're volunteers? You go to my village hall, you can do yoga on a Monday. You go to something else, you can do the WI. You know, there are so many voluntary groups. We cannot map it. And that's the problem. And it does become down to individuals to do their own research within an area, but it's a tricky one. Derek?
I'm going to walk a tightrope here. I accept the challenge about making sure that we pull out some more South Holland specific where there is good stuff. So that's a fair challenge. The detail I'll pick up with you outside of here, if that's okay, and I'll probably get Anne-Marie to run through the detail. We do have the detail. In terms of the map, it was really just, it was a way to connect with readers. It was never going to try and describe everything. And what we've got there is we've got connector support, which is our one-stop shop, if you like, that does go down to a granular level of detail. It will never capture everything, of course it won't, but that is where we connect. We do push this out via all of our district councils. We do connect in with all of our district councils via currently the Housing, Health and Care Delivery Group, and as we develop, and the more that we engage with our district councils, the better the interface will be. Absolutely agree with that. So the specifics I'll pick up with you, and I'll get Anne-Marie to follow up in terms of answering those. I think one of the issues with Boston, SK, South Holland is obviously some of the dynamics with management structures down the coast and across. So there's always different agencies that we've got to deal with. So trying to get that across in the DPH report, because I remember the first one I came to had too much detail in, so it's always a balancing act.
Yeah, yeah. That Connect, is it called, the website?
Connect to support.
Yeah.
Yeah.
Is that then, can you access that from our LCC's website? Does it?
There is a
connect
link, yes.
through-
Yeah.
link
It's a
through?
separate website. It's about providing access for all of the community groups, third sector groups, and services to put information about, we are doing this on this day in this place. And it can be quite big areas, or it can be very, very discreet, you know, dance clubs or whatever it is, in a very local position. So it's there, and it's a community resource. And the more people that engage with that, whether they're district councillors, whether they're third sector providers, the more information we get on there, the better. And when somebody does go on and they want to look at what's available, you can put your postcode in and you can see what's available in your area. But it'll never include everything. I completely accept that criticism.
No. Okay, I've got Marianne, then Mike, and then Mark.
Thank you very much. Firstly, I did use that Connect support, actually, and I did get some extra people that I had no other connection with that turned up, so that was it's quite useful to an event. The other point I wanted to pick up on, I think what you were saying, if we did the Devo deal, all of this would be up in the combined authority and not in the county council anymore. So that's an interesting way of looking at it. But I take your point, but I guess that's another discussion for elsewhere. Just having a look at the map, if I might, on page 34, which is about access to healthcare facilities. And I'm sure, as I say, it's probably detailed elsewhere, but you haven't looked, can't see here the impact of that. And presumably I know we've talked before about the length of time it takes for an ambulance to get to hospital and the likelihood of somebody, therefore, having an increased chance of more serious damage than they would have had. You know, I think there are some figures that we've done before on access, on the impact of access to healthcare. And I just wonder if we put that in, if it might strengthen the case there. And then secondly, on that map, I'm also looking at the areas, for example, Sleaford's shown as being very good, and they do have a surgery, but you talk to anybody locally, they won't say it's good. They say we wait 3 weeks to get an appointment if you're lucky. You know, so I don't know how, if there's another way we should illustrate that. Thank you.
Yeah, I think that challenge about what that map shows is about the geographical access to existing services. That doesn't unpick about whether you can actually get the appointment with that service. So I think that's a perfectly legitimate challenge. Same challenge in Mablethorpe, for example, in terms of there is a GP practice in Mablethorpe, but obviously trying to get access and the service provision and prioritisation is a real challenge. We've kept it high level for a reason, because depending on the disease that you're talking about, this map would be hugely complicated and really not understandable. And from my perspective, this opens up a question. Clearly, where the darker areas are around where the acute trust sites are. And there's a key question for us, I think, as a country, in that as we get better digital technologies, we get more mobile health and care options, we really need to consider the model of health and care service delivery we've got, because it's come out of World War II. And the idea of we will build a hospital and that'll sort all of the problems, often it's the other way round. We need to be getting all of our clinicians, all of our services, our diagnostics out of our 2 big sites and making more and more of it mobile so that we can deliver it where the need is and move it around the county. Now, that's quite a fundamental shift, especially for a hospital-based consultant who's quite happy to stay with their list and sit in their clinic. All of this is going to be opened up with some of the integrated care system work that we're doing. and redesigning our community and primary partnership model. And that will help our GP practices because they won't be trying to deal with everything in splendid isolation sometimes.
Sorry, can I speak up? I didn't get the idea of the mobile. So are you saying that a GP surgery could be mobile, or that I know we've had the mobile, the breast clinics, for example, you know, there's a number of those things that are in a lorry if you can find it. And, you know, that's one way and that's okay. But are you suggesting more of that rather than what we were talking about before was putting more surgeries in the GP practices as they are originally?
I think what I'm suggesting is we need to fundamentally redesign the model. Now, in some places, that might mean more mobile scanning. That might mean getting acute-based geriatricians out of their hospital and delivering services around Mablethorpe, for example. In other areas, it won't be that because the infrastructure will be different and the need will be different. And so we're starting a piece of work to look at, based on what the GP practice list looks like, what do those individuals who are registered with a practice need? And what are they accessing? Not just in the practice, but how often are they calling an ambulance? How often are they turning up in A&E? Which actually the GP doesn't see until afterwards. And therefore, what should be the model of health and care that we deliver in that space, that place, dare I say neighbourhood, but I'm not going to because we'll have to come up with a language for it, that will help to meet the needs of that population. And it'll be different. We know in the middle of Lincoln, because of our universities, we see 20,000 young people coming into Lincoln. And that drives the needs around health and care. And that's very different to South Holland, for example, which has a very different population demographic. So the idea of having a one-size-fits-all is wrong, but there will be a core service delivery model. Does it mean general practice as is? In some areas, yes. In some areas, no, because we can't recruit GPs. So if we can't recruit a GP, we're going to have to do something different. And we're going to have to fundamentally redesign the system to support the population. These are really big questions and big challenges, and it's going to take a lot of conversations with our communities and with the people who currently deliver services in those spaces.
But the question is, do we really think a vision of what we think it should look like? I mean, if you were going to redo say Lincoln Town Centre or City Centre, or if you went to Grimsby, there would be a master plan with in effect an outline of what you're trying to achieve through time to get somewhere. I don't think we really do that in the world of health. I mean, ironically, Louth is looking at new certain ways of scanners, and they've got one they need more, and it is certain things need to go more to our what I call the more urgent care centres, to use the right word. But then an urgent care centre is still not fully defined in this county anyway. I mean, Grantham costs some splutters on that word, but it is an urgent care centre. Louth is, but actually it needs knocking down half of it because it's just not fit for purpose, and never will it be fit for modern day vision of what we need. You know, small rooms and trying to get a great big scanner in is just a very expensive way of going about it. But, you know, you make some good points, Marianne, but we just have to wait and see. But I think this document starts to trigger a lot of those conversations, and I think the question really is, where does this document go? I mean, you have done some great documents. You've jazzed it all up. You've been very focused over the last, how many have you done now? 5? They've all been different dimensions, different angles, and they're very good. And I was sort of reading this thinking, but what do we do with them? Where do they go? And actually, we need to build on some of this work that you're doing, because a lot of time and energy has gone into bringing this all together in this document.
So I think the answer to that question is we do have to redesign our health and care system. I think it's a national challenge. It's an international challenge, but let's start at the national level. Yeah. And for Lincolnshire, we absolutely need to redesign our model. That is all being picked up through the integrated care system work, as you'll be aware. And there's a specific piece of work. So, for example, the acute trust and the community trust are now sharing a management structure, and that's a structural change, but it is already starting to see a shift in clinicians and services that were based purely in a bricks and mortar hospital being moved towards a more community-based model. That's really important, and we need to accelerate that. We need to support our general practice because in parts of the county it's falling over and it's never going to be able to meet the needs of the population. And we need a whole new model there, and that's where the community and primary partnership work is going to come in. All of this has to be underpinned by a fundamentally different approach to our workforce planning, which again is another programme, and having a medical school now is really important in that, so we can start to train our own clinicians, but that's only one small part of a much wider workforce. As I'm sure Martin will say, we've got far more people who work in social care than we have in the NHS, so we've got to tie that in as well. And it's not just one elephant, it's 6 or 7 elephants that we're going to have to eat, and we've got to break it down. But we've got a number of key programmes, one of which that's just starting and I've been asked to lead is around community and primary partnerships, and I'm really happy to come back and brief scrutiny as that develops.
I agree with that approach. Go and have a look. We've perhaps been to Centre 4, but that's start, and I agree with the hospitals joining up, the community health and the acute. I think there is some risks in all of that. When you look into a lot of the community health stuff, I think, well, actually, some of that gets more really as aligned to adults in terms of as I wouldn't say necessarily a provider, but linked in on the same sort of site because they're similar or the people require both services. But I think there is, changes on the horizon, and if it goes well, it'll be good. If it goes badly, which it could do, it's it needs to be looked at, but also a game plan and that piece of work sounds like you're going to cover off that linking in effect two together.
I think I just come back to first principles. The Integrated Care Board's budget for next year is going to be in the region of 1.6 billion, so 1,600 million pounds just for Lincolnshire. And it's not enough. We've just seen scrutiny paper, over 200 million in terms of social care. We can't just keep trying to run faster and faster. No. There isn't the efficiencies. People can't work any harder. So what does that mean? Well, either we find a way to put more money into the system, but I'll say again, 1,600 million pounds just on the NHS in Lincolnshire, or we redesign the system and have a new conversation with everybody in Lincolnshire, whether that's the public, whether that's clinicians, whether that's social workers, whether that's families, and figure out what it is that we want to help people lead a good life. And that's where I think I am, and will probably be the focus for next year's DPH report, just to give you a little teaser there.
Yeah, well, thank you for that. Mike?
Thank you, Chairman. Thank you for the report. Interesting reading indeed. Several points have already been discussed I was going to bring up. But prevention is what I'm keen on, and certainly about your falls at home and the scheme there is very good. I wonder whether we could use our own magazine and the district magazines to promote that throughout the year to coordinate. And certainly with winter, we've just had one little bit of snow, nothing much, but obviously shortly we may have more snow, more ice, and that's a key element because I'm in that category that I don't go out when it's snowing or it's icy because I'm likely to end up, breaking something. So I think that is something that we can maybe promote. And I like the comments about isolation, that, you can't always get people to go. But in the report, it mentions the preferred medium is the written word. And again, I'm wondering whether we could utilise the magazines that we produce or the district papers that we can utilise, and then try and do it in such a way that the magazines don't do it at the same time. So there's a double hit, if you get my meaning. And I think promoting warm spaces seems to help a lot of people who are sitting at home if they're cold, but if they know they can go to a warm space, they can then communicate and feel better. I've seen an example of that in the St Giles division, and that's worked well, and I'm sure there are lots of other places where that warm space element is very productive. We've mentioned housing, which you said that is a big problem, and I have mentioned it before about not quite sure whether we convince people living in isolation to downsize, so therefore they're not trying to cope with a big house, and it may be then moving into the extra care housing would benefit them as well. But I don't know how that, I'd not say push it, but it would be a suggestion to people, and then try and persuade them to do that. I'm delighted about the Dewin Court experience, and I'm not quite sure whether we could produce that, as you say, to look at areas where it's needed. And the forecast you were mentioning, Martin, about looking at areas where the need is and trying to forecast that. And I think that's brilliant that you're obviously going to cooperate more and come together and provide us, or provide our residents with the right kind of care and well-being. Thank you both.
Thank you.
Can I just come back on that? If you read my report, the Falls number is in there. We sent it out, didn't we, John, just before Christmas? In my monthly report that I give to all councillors. It has been in the county news as well. We did an article on there not long ago, but we can put the number back in there, can't we, John? Again, he's not looking at me, but he will do in a minute. But we can reiterate the number. But if you look at my report, I think it was last month's or the months before, it was definitely in there, where you've got a direct number for that Falls rather than ringing the ambulance service. I agree with you, but it's a matter of county and districts working together on these housing. We do, where possible, try and get people to look at their lifestyle basically earlier. I mean, that is what the Housing for Independence that all the districts signed up to quite a few years ago from the Housing and Health Care Delivery Group. I mean, I'm 61 now. We're looking at downsizing, taking responsibility for our own housing and our health, and how we're going to plan our future lives for hopefully the next 30 to 40 years. But obviously where I live, Derek, my map goes to show that I'm going to be dead a lot sooner than that, but I'm going to prove you wrong.
I mean, on that warm homes, I mean, at the minute it's pretty focused who can apply for it, isn't it? Can it be opened up more?
There's been a lot of changes in terms of national government grants around the broader area around warm homes, and we try to bring all of that together under the Housing, Health and Ageing Well programme. And actually some of that work we've done at a Greater Lincolnshire level, so it comes back to your point, Chair, around this might overlap with a Greater Lincolnshire devolution approach. The more that we can get into Lincolnshire, Greater Lincolnshire, the better, absolutely. But equally the argument about people who maybe had children, lived in a house and had an income because they were working and could afford to keep that house warm, if they stay in that house longer term and as the house ages, the ability to keep that house maintained and to heat a big home when actually it might only be one or two people in is a real challenge, and we see that across the country. But we've got to have the right sort of housing stock, and obviously that's where the district's interface comes in. So you either buy a house that you can live in for your entire life when you buy your first house, or you recognise you're going to have to adapt or change your housing stock. So absolutely agree with all of that, but it's a big challenge for people who've lived in one house all their lives and they've brought their kids up. The connection to that home, because it's not just a house, it's a home, isn't it, is massive. And then we have people who can't get into the right sort of housing stock. It's a huge challenge.
Okay, I've got Mark, then Rob.
Thanks, Mr. Chairman. My second sort of point, I think quite a bit of it has been covered by the conversation between Councillor Overton and some of the points that she made. Because I was looking at the map of the access to healthcare. And it was interesting to see that even sort of in the areas where you would think there'd be good access, I'm struggling to find any real dark blue areas. And obviously, the point about Grantham, obviously we no longer have an A&E in Grantham, and I would totally support Councillor Overton's point about GP practice surgeries. Yes, we got quite a few, but trying to get, as I found out recently, an appointment is very, very difficult. And I have quite a few, quite a few people approaching me, and we know that nationally there's a shortage of GPs anyway. Grantham is a growing town, population likely to go up by 20,000 over the next sort of 15 or 20 years. So there very much is that sort of requirement of that. But just one sort of recent example that affected us. About 4 months ago, my wife had a slight fall in our garden and fractured a very hairline fracture on her left foot. Sorted out at Grantham Urgent Treatment Centre and back. Now, previously, there's been a fracture clinic in Grantham. So we were quite expecting the follow-up would be at the fracture clinic in Grantham, but nope, they no longer do the fracture clinic in Grantham. You have to go to Lincoln. So 2 trips to Lincoln, an hour's drive, for an appointment that was like 5 minutes, and then back again. Both times struggling to find a place to park in the car park at Lincoln County. Now, and we're fortunate because we had a car we can drive. So, but if you were going up either by patient transport, you probably have to spend the whole day there, or making your way on public transport. But I think the wider point I'm making is that, as somebody who worked in the health service for 25 years, when I started working in the health service in the mid-1980s, there was a very, very flat structure. There was the Department of Health, and there was the Health Authority. And every year, because I started working in South East London for Lewisham and North Southwark Health Authority, and every year the money came from the Department of Health straight to the Health Authority, and the Health Authority went and did everything. Now, as I worked in the health service, every year I seemed to work there was more and more levels of bureaucracy kept being added. We had the purchaser-provider split, we had a provider trust, we had PCTs and CCGs and a whole plethora of different things that kept changing every few years. It always struck me as somebody who, after working in London, was then working regionally around East Midlands, that the model of care that we were expected to deliver in rural areas had been designed for urban areas. It had been designed by civil servants in London as this is the model we're going to impose on the whole country regardless. Now, having certain hospitals doing certain things works fantastic in London, works great in Nottingham or Leicester or any other big city, doesn't work in a large rural area like Lincolnshire, which is why I'm pleased, Derek, that your comments said that we are trying to devise a different model of care. Because fundamentally, because I actually did a little bit of reading into the history of the health service, and when it was initially formed in 1948, you can actually look at the cabinet papers around the discussion that was going on. Nye Bevan wanted a national NHS service, which in effect was, that's the NHS system, whereas some of the Labour cabinet, Herman Morrison, wanted a more regional system to take account of these regional differences. Bevan's view won out, so we got the national model imposed. But my point would be 70 years later on, the national model doesn't work. And actually what we need is more of a regional type of model that takes account of all these differences that are there. So I'm really pleased that we are doing that. But how long is it going to take? Because I definitely do think we need a different model of care for the NHS. We need one that is a genuine rural-based model for Lincolnshire. We also need to get away and try and just rid ourselves of all these tremendous levels of bureaucracy in the health service, because we've got the Department of Health, we've got the NHS Executive, there's a whole variety of other bodies around there. It's just, you know, as somebody who worked in it for 25 years, even I struggle sometimes, and I know my colleague Rob, who's worked in the health service for many years, we've had these conversations. It's bureaucratic, it's over-managed.
Can I just say, I fully support what you say, but we're talking about active ageing here in this document, and it's sort of we're drifted into the world of NHS, which this document isn't really going into. But you're right, it is. But I also think, and I'm a believer of this myself, and that's my opinion, is that we cannot expect every hospital and every site to do everything, because you're not going to attract that level of expertise into Lincolnshire, where Grantham can have the state-of-the-art surgeon that knows how to mend every severe broken issue. But you're right, it's overcomplicated. But back to active ageing, and this is what this really is mainly all about. I think, having gone through it, ironically, you talk about transportation. A lot of what I get is we're not very good at transportation, certainly in public services and in and around Lincolnshire. But I would just, one of my things in noting on this is we are focused on the elderly, but actually when having meeting people referenced devolution and in effect what's the mayor do, it's amazing how many people are saying we get too much when we're older. We get free bus pass, we get free this, we get this, that and all the other. The youth haven't got anything anymore. They can't get on a bus because there isn't one. They can't do this, they can't do that in our rural areas. And actually the elderly, we're talking a lot about the youth. And the fact that we are so now focused on the elderly that we're forgetting, if we're not careful, the youth. And by that, when you start to look at somebody that's, say, obese as an elderly person, you then see their child following that's also obese. And if we're not careful, we need to focus on our youth being active, because if they're active, they will take it through when they're older. If we just focus on the elderly all the time, the youth is following through, because if the parents or the grandparents are not active and not really promoting their health, it will not go to the offsprings very well, and in effect we're just dragging the same headache along. So just bear in mind the youth with this, because they're going to be the next elderlies.
Yeah, I absolutely agree with that, and I think we've previously done a Director of Public Health Annual Report. Obviously this one, it was with Glenn as the previous stats, and I did one with Heather around children and young people coming out of the pandemic, you may remember a couple of years ago. Our approach as a system is start well, live well, age well, die well. Now, clearly this particular report is focusing on part of that agenda, but to give scrutiny assurance, we do focus on all of those aspects. We spend a third of the public health grant in terms of children and young people. We have a family weight management program now that's focused on both the adults and the children in terms of helping them to increase their physical activity, diet, nutrition and maintain a healthy weight. So absolutely agree. I think the cross-cutter here is we've got to focus on prevention, because focusing on treatment and trying to solve problems as it comes through the door is not sustainable, whether it's in terms of the adult social care budget or whether it's in terms of redesigning our health and care system. And you could argue, going back to the 5 giants, all parts of our approach, in terms of how quickly we can do this, I think we've got 5 to 10 years to redesign how we do it. Otherwise, we're going to have to redesign how we fund it.
Yeah.
And that's a national debate.
Yeah. No, I agree. And just one last comment, which isn't in here, but it technically does. Volunteering. We don't do it very well at LCC. And I was speaking to a volunteer about it, and he did just say, look at what Lincoln Cathedral does, because they really empower their volunteers. And I think it's something that we should start to look at, because I think volunteers are a way in which we need to really embed better into our systems for support. Right, I've got Rob and then Marianne to finish off.
Thanks, Chairman. All I was going to ask, Chairman, was Derek was talking about the website, which has all the information about groups. I was just wondering if that information could be given to all members of the council, so that we have that as a reference that we can give to our constituents.
Yeah, what we can do is include within the scrutiny minutes the website address, because it's it's linked through from our website, but it is a separate website, so we can include that, and then members can go in, because you can go down to district level, you can go to primary care network profile, so they're all different depending on which area you cover. So we'll do that, if that's okay.
Do we have a forum of elderly people or those with special learning disabilities that actually look and analyse our website in terms of pathways, information and data, to see that it really is easy to follow rather than we all think it is? I suppose that's John's, perhaps. Just whether we had a forum that in effect looked at the way we display our website and the information, and if it's really easy to signpost for people with learning disabilities and elderly people. We keep talking about training the elderly to become more web savvy, but if it's not very friendly to actually navigate, it's never going to be savvy, is it?
Yeah, I mean, our digital communications team look over the website, so I think that's a question I'll have to ask them. I'm not sure what they've got in place, but I think we do have some sort of forum base, but I'll come back to you on that.
All right, thanks.
Can I just add, is this the Connect to Support website? Because it doesn't look very user-friendly to me, if it's that one.
No, so the Connect to Support website is where voluntary community groups, people who are providing services or people who are after services can go on, put the postcode in and find out what's going on around them. The website that we've got a lot of this intelligence on is it's lhih.org.uk. So it's, if you remember, we used to have the Lincolnshire Research Observatory, which was where we used to put all of our public health analysis. We've updated that to make it far more interactive. It's where the Director of Public Health Annual Report videos will be on, for example. So it's lhih.org.uk. We'll put it in the minutes, but that's where a lot of the intelligence is that you can look at in terms of your own constituencies.
Yeah, this one where you said put your postcode and it comes up, I am looking for it. You don't put your post. This is the Connect to Support one.
There's different ways to search it.
It don't look very. I was struggling to find anything basically. Anyway, I just thought I'd mention it. Thank you.
We have done training for councillors in the past, and we could put that back on again. Actually, if that would be useful for people, because there are different ways to look through this site.
Don't know whether it's been mentioned, but we have got a permanent address on the back of County News now for Connect Supports. That's there all the time. You know, for our services page, you know, look out for. It's there on there as well.
Okay. Thank you. Marianne, then?
Thank you. Just a couple of small points. One is to let you know about the warm homes grant, the various warm home grants, and I have just been researching this lately because I had somebody write to me and say, is the company that our council is recommending, is it kosher, or is it just a, a make-up one? Because they hadn't been able to make it work. And I think the current grant system for being able to access grants for your home is really difficult. And our council's been putting in applications in small batches, and each criteria has a maximum cap on it. You can't have in that batch more than this, in installation more than that. It's just very complicated, and that is destroying the system. It's making it impossible for people to get the grants they need, and certainly in a timely way. One person was telling me she tried to get it before last winter, and she's now in this winter with nothing. Really cold house. So I think there's a lot, that if we had maybe a member of staff working on that, Maybe we have, but that's something that we could really do with, and also lobbying central government as well to get some of those rules improved. Even the fuel companies are supposed to be giving grants for insulation, but again, really hard to access. So I would like some more work done on that by the councils. I think it'd be worthwhile, and it would bring good money in as well as good health into Lincolnshire. Then the other thing is, just on the, going back to the access to healthcare, I do still think some more work would be really good to see on that. I know you said it's complicated to put everything in, and of course it is, which is why you got the question you did when you did put something in, because you did the opposite on the next question, where you did put some things in. And I think just a few little case studies would be really interesting, because I do think a local service has got to be part of the new model. I'm really concerned if people are thinking that they can close all these GPs and they'll just have a new building, spend I don't know how many million on a new building. You know, we used to call them hubs, didn't we? You know, I think that's a really bad idea. This, you know, strengthening what we've got, I think would be really effective. And I support your point about getting people out of the hospitals to work there that you made, a very good point. And also, as we've talked before, about upgrading having nurse-led services. You know, there's lots of ways we can do to reduce the need for GPs. But, you know, I think those actual access to something local remains really vital in people's minds. Thank you.
Yeah, it's how we determine local in an vast area of Lincolnshire. You know, that's the challenge. Right. I think, well, personally, I think it's a very good report. It goes into great detail, and it's something that public health and you know, to promote, and it brings a lot of things together. I think I don't just want to see it go on a shelf. So looking at this then, Simon, I think it needs to sort of come back into us at some point in the future, sort of 4 months down the road or something, in a way how we can sort of keep the document alive but sort of add more weight and support. And I think in some sense, maybe you've touched on it, is when we've talked about community-based services, working with partners, I think maybe bring something back that starts to sort of build the picture. Because I think, you know, if we don't start the journey and we don't start to map it out, we're never going to shape really what we want. It's, at the minute, it seems to be in everybody's head and vision of what everybody wants, which is all different, and we're nowhere near aligning on it all. So I think let's start, and we'll work on something to bring it back in about 4 months or so. Yeah, Derek?
Yeah, happy to do that, and probably locate it within the wider integrated care system development and the community and primary partnership work that we're doing. I've just had a quick look on the Connect to Support website. If you go into the provider directory, that's the bit that because that tells you what the services are around you. And I've just put our postcode in here. Within 1 mile, we've got 170 different services within 1 mile of this site. So that's the sort of granularity. Now, obviously, that's everything. If you want dementia services, then you'd narrow down your search. But the more that, as councillors, you can get these messages out, the more we can get on there that's very local. Clearly, we're in the middle of Lincoln, so it's different to some of our more rural areas. But it's the provider directory that you might want to share with your populations.
Okay, well, thank you very much. Thank you. Right, so on that, then we'll go to the next agenda item, which is the proposed actions in response to the CQC Assurance Pilot Assessment. So, I'll let you take it away, Martin.
Okay, thank you.
Well, thank you, Derek, and I think you've been very thorough in this paper, by the way. Well, talking to Martin on this CQC paper, but I think, and some of the contract stuff will come back into what you were talking about, Derek, on your previous, but thank you for your paper. So Martin, as I say...
Yes, so as Derek slips away. So as members of the committee, you'll obviously be aware, one of the it's really now the major plank of the government social care reform programme that remains is the new process of assessment, I think is the current term that they're using, assessment of local authorities by the Care Quality Commission, the CQC. CQC ran a pilot process during the course of the second half of last calendar year, and Lincolnshire was one of the 5 authorities that put ourselves forward, as you're aware, and that process took place during the course of the summer. CQC were very keen to ensure that all of the reports were published from those 5 pilots, all published at the same time, so they could do some work in consistency and calibration. So although the work was done during the summer, the report wasn't published until the 17th of November, which was just before the last meeting, of course, of this committee. So you'll be aware that the CQC has adopted the same rating system as now pretty much standard across the public service of outstanding, good, requires improvement to be good, and inadequate. They had a number of elements, 9 elements underpinning each of those overall scores. So Lincolnshire was the only authority in the country out of those 5 where not only did we get a good rating overall, but we were good in every single one of the 9 elements. And it's worth noting that of the 5 pilot authorities, and therefore the 45 scores that were given for individual elements, not a single one of those 45 elements was rated as either inadequate or outstanding in any of the pilots. So they were all requires improvement or good, but Lincolnshire was the only one where we had good for all of them. So as things stand at the moment, Lincolnshire has the highest rated adult social care service in the country. Who knows what will happen? CQC has notified 3 further authorities that they will be the first of the first wave of rollout, and we are expecting that they will start to notify further authorities. Their intention is to do 20 a quarter, so to get through the whole country in about 2 years. I think they will find that quite a challenge. Although we were rated as good across all 9 elements, and this was the best of all of the pilots, nonetheless CQC did identify under each areas where they felt we could do more and we could do better. And of course they didn't rate us as outstanding, so by definition there's more that we can and should do. So what we have been doing is looking at those statements and considering what we should do next. One of the areas where CQC, interestingly, are different from Ofsted, and it's worth noting that CQC seem nationally to have essentially taken the view that if Ofsted do something in one way, CQC are going to do it in a different way. They are different businesses, but I'm not entirely convinced that that there isn't something that can be learned from the experience of Ofsted. And I say that having been a director of children's services and having been inspected by Ofsted in every which way that you possibly can, and there are some strengths in that system and there are some weaknesses. One of the ways that CQC is different from Ofsted is that after Ofsted do an inspection, they require the organisation to produce and submit an action plan that directly addresses the areas of improvement identified in the report. They don't then monitor that plan, but it feeds into the ongoing engagement that Ofsted has with the local authority. CQC has not gone down that route, so we are not required to do anything with the report that they've given us, nor in fact do we have at local authority level. We'll come back to CQC at a provider level when we cover Alina's report in a minute. But at local authority level, there is no ongoing engagement with CQC. There is there's no forum for me to have a conversation with the CQC about their report and what they are expecting us to do. Clearly, we're not in a position that we're going to say, well, that was interesting what CQC said, put it on a shelf and then just carry on as we were before. So we are in the process of reviewing those actions, and really the sort of core output of that is in the body of this report. But just before I go on to that, I have very deliberately taken the view, working obviously in guidance with Councillor Boquet as the executive member, that it is probably not valuable, given that the CQC haven't asked us to produce an improvement plan just for them. It probably isn't helpful for us to produce an improvement plan that just looks at the CQC issues, and then we have a separate one that looks at other issues. So I'm very keen for us to avoid the risk of having a multiplicity of improvement plans. We'll just trip over ourselves if we do that. So what we're seeking to do is to build these issues into the wider improvement plan for the Directorate as a whole, for adult social care specifically. So in that sense, there won't be a CQC improvement plan, but there will be a plan for the Directorate. What we've done is for each of the areas that CQC identified, and there were only 6 areas that they identified, that we've produced a template which we've attached to the report, just setting out, well, what exactly was it that the CQC said, so that we can be really clear. There's no translation process. We haven't interpreted for you what they said. We have quoted what they said. We've noted what we have already had in train, and I think that's a really important point, because there wasn't really anything that CQC said that came as a surprise to us, and that's a good thing. No surprises is a very good policy. We had, of course, as part of the preparation for the assessment, we had done a self-assessment. This is a key part of the process, and so there were a number of areas that we had identified in that process where we'd say, yes, actually, there's areas for improvement there. And to a very large extent, CQC agreed with us in that, and so therefore things were all largely already in train. So we set out what we were doing there. We have set out then on each template the proposed further actions. What are we going to do in addition to what we're already doing? And then the last thing we've done, and I'm particularly keen that we had this, is to have a statement about what does success look like. And so we've had conversation previously in this meeting about a strength-based approach, and I was very keen to ensure that the team, when we're looking at how do we go forward here, have a clear sense of, so what does this mean for Lincolnshire residents? What does success look like for the people of Lincolnshire who might need to draw on care and support? And that is the key measure of success. So we could have wonderfully efficient and effective processes, but if it didn't link with what people want and need, then we wouldn't be hitting the mark. So really, that part of keeping the person at the centre. So we have the series of appendices attached to the report that set these out, and we will then be using this information to build into the wider improvement plan for the Directorate as a whole. I'm happy to answer questions about the individual elements, but I think that was sort of covers the broader picture.
Thank you. Well, I think it's very well laid out, and I like the way that you put it together, and the fact that you have put on the back what we would like to see it be as a service. So that's very good. The only one thing which I sort of was really in terms of safeguarding, it talked about a letter being sent out, but I think also it needs, and it does mention it a bit, but the word training needs to be a bit more emphasised in that, in terms of identification and all the rest, because in effect that was the bit that was needed. The letter is in effect saying how to do it. It was really then the training sits on the back to deliver the actual outcomes. But other than that, I thought it was a very good response back to CQC. Well, for us, like you said, embed it into the system, and we've sort of taken on what they've highlighted and are going to adapt accordingly. Mike?
Thank you, Chairman. I was going to raise a question regarding safeguarding, page 71 of the report. It says, you know, it doesn't meet the criteria, but obviously not being in the business, we don't know what those criteria is. And I'm wondering if we don't give if the person doesn't meet the criteria, are we advising them where next to go rather than just cutting them off? And similarly, I presume we do keep case notes on any inquiry that comes in so we don't fall foul of ignoring somebody. And similarly, are you able to give us an example of what an inappropriate or a referral that doesn't meet the criteria? Thank you.
So I'll try to pick up the various elements of your question. I think it's important to draw a distinction between referrals we get, safeguarding issues that get raised by members of the public compared to safeguarding issues that are raised by statutory bodies. And the concern we have, so if a member of the public raises a safeguarding alert, then we will go back to them and let them know what's come from that. Clearly, sometimes there can be issues of confidentiality, but we'll tell them whether we're proceeding or not. The issue, the real issue that we have, which was picked up in the CQC process, is that partner organisations are flagging safeguarding issues, which they're then passing to us for our consideration. And when we look at them, it's pretty clear in an awful lot of cases that actually this doesn't meet the threshold. Either that it really isn't a safeguarding issue at all, or that it clearly doesn't meet the threshold for it to be investigated, that there are other approaches. Perhaps a good example of this, and actually we were discussing this as all of the directors across the region just on Friday. So our colleagues in the ambulance service in EMAS, every local authority in the region receives a very large number of safeguarding alerts from EMAS staff, and all of us find that a very high proportion of those alerts are nowhere near the threshold. That Section 42 inquiries, there's a national guidance as to what constitutes a safeguarding issue, and a very, very high proportion of the alerts raised by EMAS staff don't meet the threshold. The expectation is that staff should be trained to understand what is genuinely a safeguarding issue and what isn't, and that statutory partners have processes internally to review the referrals that are made by their staff. So, for example, if a police officer wanted to raise a safeguarding issue from something that they had seen, they should have received training that they would be able to understand, is this safeguarding or is it not? And I'll come on to that in just a second. And they wouldn't just submit it directly to the safeguarding team here. It would go through a process within the police force, and the police, there'd be a place where that gets pulled together, and someone in the police would have a quick look and say, oh yeah, that looks reasonable, I'll pass it on, or no, hang on, we haven't quite got this right here, and would pass it back for review. EMAS have told us that they don't do that. They simply pass through everything that is submitted to them, no matter how ridiculous it might be. So we have had situations where a medication check call has been missed. So someone is supposed to receive a reminder, either someone popping in or getting a phone call to say, have you taken your tablets? And that call hasn't happened, and that's been flagged as a safeguarding risk. And I think very clearly that's not a safeguarding risk. That's an issue that's a weakness in the service, and it may well be something that we would want to pick up. That might want to go to Alina and her team to say, well, hang on, they've missed this medication call, this medication check. That's the 20th in the last 6 months. That sounds like there may be a weakness in their processes, but it's not a safeguarding issue. And so we're finding the risk is that the safeguarding process is being overwhelmed by so many referrals that we have to go through. But when we go through them, we say, no, this just isn't the right thing. And the analogy that was used to me a while back in a related situation is that when you're looking for a needle in a haystack, you don't start by making the haystack bigger. And that, in effect, is what we've ended up doing, that we're getting so many referrals in, just in case. It's actually meaning we are less likely to be able to see those cases which really are safeguarding issues where we need to do something. But clearly, where something gets raised and it's found not to meet the threshold, that will get recorded on the case notes, and we'll get we'll make sure we've got a record of that in terms of the provider, because as I think as you're indicating, one thing might not be something, but if you keep finding it, then it might lead you to look into something, possibly through a different route, as a contracting route rather than safeguarding route. But we do make sure that we pick those things up.
That's valid, but I think that really does need to be rolled out to all the partners involved in safeguarding, because they're in effect, their lack of sort of some of the understanding is causing us the major headaches. And it's something that really needs to be addressed. As we say, we are sort of reacting now to every little need, and of course, before you know it, you miss the bigger ones that we actually want to be focused on, because if you've got 10,000 and we only need 14% is actually really at risk. And there's a huge scope of people, and it takes time to go through them all.
And I would completely agree that sending a letter to tell people to do the right thing is part of the process, and one of the issues is sometimes flagging to the senior leadership of an organisation that their staff are and their processes aren't doing quite what they should. But yes, I would fully accept that simply sending a letter to people to tell them to do the right thing isn't in and of itself going to be the decisive thing that makes organisations change their behaviour.
Yeah. Rob, then Marianne, did you want to come in? Was that?
Thanks, Chairman.
Rob.
Yes, I was interested to read on page 75 about the suggestion there should be autism champions, and that there's going to be a report coming to this committee in due course from the ICB. I was just wondering, have we got any more updates on the idea of the champions, and is that's going to be across every area? I'm obviously thinking from my position as Chairman of Children and Young People Scrutiny that we will have champions in our area of interest. And also I was just on page 82, Appendix G, which I found really interesting. I mean, it's a really useful document about autism. I think that was absolutely useful. I'm going to keep a copy for reference. But I was just a bit unclear on page 82 of that, that there's a line that says those who identify as female. I take it that that's a minority group, but also perhaps it should include those who identify as male. I take it we're not talking about the female population as a whole. That's a specific group. Thanks, Chairman.
So we're very much looking forward to bringing a more detailed report on autism to this committee. I haven't got a further update. In terms of the champions, that work is underway at the moment. But yes, there are various elements, as you say, and I think you're right in your interpretation of what it said in that on that part of the report.
I actually thought that the being a champion was actually a very good approach, and made a lot of sense rather than going out and reinventing a whole new approach. I thought the response for autism and the way you sort of want to shape it seemed to make very good sense. Did everyone else think the same? Yeah. So, good news. Tracy?
Thank you, Chairman. Just got 3 or 4 points on different ones, so I'll kind of do them all, and then if that's okay that way. So my point was on page 71, again, about the safeguarding element. But I actually read the report to be very much about more of a communication thing, rather than the training, and that too many referrals are going to be put in, because it actually says what action was being taken if a formal investigation did not take place. So to me, they're saying they've looked at other cases and actually the communication hasn't been very good. So I don't see that sent in the letter saying, hey, don't send us the ones that we don't want, I don't think is cutting it, and neither is the training. I think I read it to me more about that we're not going back to these people to say an investigation didn't take place, but this process did happen, or something like that. Obviously, you've seen the fuller report, but for me, that's very much, and I see communication as actually lacking in quite a few other points as well. So then on 73, again, I read it quite differently. So all of the actions were about content. The actions weren't about the ease of the site and everything. And I think the people who are reviewing the content are people within adult services. They're from a professional angle. They're not from a layperson's angle. And that's often the people who's going to be looking at these sites. And I think it's two very different heads. It's two very different languages. And for me, the actions really didn't address the true issue that it's not a huge issue anyway, but it's an issue that was picked up. So I just didn't feel the actions addressed it enough there. Page 88, I'll be honest, I would potentially challenge the waiting list comment because it seems to suggest that it's a very small waiting list of waiting for an assessment, and in other teams there's less than 100. I speak to residents regularly who are not getting assessments that they need, and quickly enough in regards to mental health. I know the Change for Links waiting time is immense for people at the moment, so I don't know where those figures come from. They must be fact, but from a user and from speaking regularly to residents, I personally would potentially challenge that. On page 90, I feel that, again, that communication theme, so on page 90, on page 98, as well, it's again, and not 96, it's about that clarity for the family. Are they knowing which provider is doing what? Are they getting the communication of the transitions throughout it? Having been through this with my mum in the last 2 or 3 months and with my partner's family in the last 2 or 3 months, I'll be honest, no. As a user, the communication wasn't there to actually know who is doing what bit, what is actually happening. And I would also say I think assumptions are made. So we mentioned the community connectors within page 98. And it sounds lovely, but I didn't come across them once in both of my discharge situations. Not once were they even mentioned. It sounds good on paper, but you know, where are we really making sure that they are connecting? I think there's assumptions made by discharge teams, because I didn't get asked, is my mum's transport sorted? Has she got food in her fridge? Because I'm stood there as a family member, it's assumed that I'm going to be able to do it. So again, on paper, I think it looks great that we've got this available, but is it being offered to everybody equally, or are we assuming because a family member's there that they're available? I was, and I'm happy to do it, but I didn't get that offer. And I think they're my comments from it.
Okay, thank you for that. No, I mean, there's a number of elements to that, but as you say, there's sort of consistent theme, which is that question of communications. And I think communications, it's one of those things that can always be done better. I would challenge any of us to point to an organisation that's got it right. There's always scope for improvement, and I have no doubt that there's scope for improvement within the adult social care service here. I think really what I'd refer back to some of the comments earlier about a strength-based approach and putting people at the centre. And so I know that there has been a fair amount of work already done under Glenn in terms of adopting the strength-based approach and having a co-produced approach. There's an awful lot more that we can and should do on that. And it can be quite startling sometimes to understand what it is, how it is that people who are drawing on care and support and their families, how they see things, because it can feel very, very different from a service perspective. And I'm sort of reminded of a couple of examples. At the very, very start of my working life, I worked in benefits offices. And the classic thing would be when someone rang up, that we would need to identify who they were. And so the staff would ask people to tell them what their NINO was. And people say, my what? Yeah, your Nino. And it was the national insurance number, because on all of the documentation that we used, it was always NINO. And so Nino was the language, but it was utterly incomprehensible to members of the public. But it was quite hard. We just thought people hadn't heard us, or they just, they didn't realise, of course they know that they'll need their national insurance. And it was, well, there was no of course about it. And it took quite an education programme within the organisation to get people to understand that that bit of jargon for us was entirely incomprehensible to members of the public. Another example, more recently, in my last authority, we realised we had some issues about annual reviews. And that process wasn't particularly running smoothly, and so we worked with a group of people with lived experience to get their perspective, and they told us that they dreaded the annual review process, and that they would have sleepless nights in the period when they knew that brown envelope with inviting them to have the conversation was going to come, and they found the process threatening and really hard to understand and deeply unsettling. And that was a huge shock to us, because actually that wasn't the intention at all. And my team in that authority worked with people with lived experience. We completely redesigned all the forms, we completely redesigned the screens on the computer, we redesigned all of the letters, so that we achieved what we were trying to achieve anyway in the first place, but in a way that was clear and understandable, and people were able to say, actually, I feel this is my annual review, and actually it's a good thing that I'm having the opportunity to discuss my situation and what I want to achieve in my life with professionals. But it was fundamentally an issue of communication, and so I think I'm rather long-windedly saying yes, I completely agree with you. So I should stick with the shorter version, but yes, I agree.
Okay, no further questions. So I think all in all, a good approach, and I suppose best things to sort of bring it back sometime, perhaps early autumn, really, isn't it, to sort of just gauge where and how we're progressing. Well, June, we're talking about the transitional bit, bring it back, aren't we, and looking at a bit into detail on that. Or will you be in a position to bring more back? Or yeah? Okay. So we're sort of going to look into the transitional of the children going to adults, just because there's a few issues there, and just check everything's all okay on that one, and an update on the rest will be good. So, okay. Right, on that then we'll go to, thank you for that, we'll go into the overview of care providers contract management. So I welcome Alina Hackney and Rachel West. Good paper, very well laid out. Thank you, Alina. Reads very well. Good bit of work, actually. Brings it all together in one document, which was really very good and positive. So thank you.
So I'm going to say just a couple of words of introduction and then hand over to Alina. And I just wanted to pick up a couple of points. So as I think Derek mentioned earlier, it's a fact that often gets overlooked that more people work in adult social care than work for the NHS. It is a significantly bigger employer, but rather than working for the single NHS, they work for something like 18,000 different organisations. So it's a very, very large service, but it's very, very complex and very disparate. It is in the external market, it is the large majority of the adult social care budget. So it's something like 85% of the adult social care budget is spent on external providers. And as the report says, there's something like 600 different contracts across Lincolnshire. And we're not talking small amounts of money even per person. I think the average spend per person is about £17,000 for people who draw on care and support. So it's highly complex. It's very, very substantial, and therefore it is absolutely critical that we get this right. I did connect with another council in a different region some years ago who were talking about their contract management approach. And they said, yes, we've got a commissioning approach, a very slimline approach. The contract manager is the chief executive. And we don't really need much more capacity than his time. That's fine. I think I could probably hear Alina collapsing at the thought that we might try to manage something like 170 million pounds worth of contracts with 600 different providers for several thousand people to try to manage that with a little bit of Debbie Barnes's time. It is absolutely critical that we do this work actively and thoroughly and comprehensively. One of the questions that sometimes gets raised is, well, why do you need to do that? There's the Care Quality Commission. Don't they do all this? Aren't you simply duplicating what they do? And I think the answer to that is a very firm no. The CQC is the regulator. They check that people are operating legally. There's a world of difference between checking that someone is operating legally and making sure that they are delivering what it says in the contract. Those are two very different things. So we have to be very robust in what we do. We have to be very thorough, and we have to recognise that sometimes things go wrong, and therefore we have to be ready to identify and address that. And one of the things that I've had many years of involvement with contracts. The best contract is the one that you never have to look at because things have gone right, but things don't always go right, and therefore you can't assume that in your contract that things will. You need the contract for when things go wrong, and you need the team that can manage that. So that's just a little bit of sort of context, and now I will hand over to Alina. Hopefully I haven't stolen too much of your thunder.
Thanks, Martin. Actually, that's a great introduction, because our mantra in our team is if we have to get out a contract with a provider, we've failed badly. It's based on really good, sound relationships and mutual respect. Obviously, there are times when you do have to rely on the contract. I think we've got a presentation to go along. Is that okay? Just to give a little bit of context, our approach to this, we could take a whole morning talking about all the different processes and how we operate. So this is some challenge getting it in for the next 20 minutes. But the approach we're taking is really as a follow-on from when CQC representatives joined this committee. I think it was at the back end of October. And they came to talk very generally around the state of care, which hadn't been published at that time. And so this is really a follow-up from that, because, obviously I'm acutely aware at the time members were asking really, really pertinent questions about, well, if that's going to be your approach around inspection for the future, things can fall down gaps. And myself and Rachel are here today to hopefully provide assurance to this committee around how we have oversight in managing the market. So we will look, part of this presentation is how contract management works in adult care and community wellbeing. But also what I want to do is just bring to life, because the State of Care report has now been published, and I just want to draw out 5 themes from that and compare it to Lincolnshire. So if you remember when the lead inspector came, she talked in very general terms. What I'm going to do is play back what that looks like in Lincolnshire. Okay, thank you. Next slide. So Martin's covered off this quite a lot, actually, but I'm just going to set the scene. There are 600, just over 600 contracts, and that equates to 1,006 settings. Just to give you a feel for what that is, so we have oversight of all residential-based type services, so things like care homes or active recovery beds, so where they're 24 hours in a residential type setting. We have oversight of the community-based services, so that's things like home care, community-supported living, daycare, all those services that are delivered in our communities. We have a range of services across clinical, services, so things like sexual health, health checks, we cover that span. That's really within the span of public health. And then we have our strategic portfolio, and there's something around about 32 of those. There are county-wide services. So, for example, things like our reablement service, or our wellbeing service, or our carer service. So the span of services is vast across those. And as Martin says, the vast majority of services within adult care and community wellbeing are externally commissioned. That's the makeup really of those 600 contracts. So there's the annual contract spends around about 210 million, so a significant part of their budget. Now, to give you some oversight, so CQC shared with you when they came about their approach to inspection, and they talked about it could be as long as every 5 years. In the last 12 months alone, we have conducted 1,200 site visits, okay? So that's the first kind of point I want to give around assurance that every single service, those 1,006 settings, will have a form of assurance visit. Now, they look very different depending on what they are. So some of them are site-based, some of them or not so, but information is gathered about those services. And as I say, Rachel will cover off, how we assess risk in terms of determining which are our key priorities. Fundamentally, contract management for us means 3 things. 10 years ago in adult social care, the market was broken in Lincolnshire, and that was mainly borne out poor commercial arrangements and contract management looking a little bit how Martin described there. It was perceived as an add-on to someone's role. You have to invest time in those relationships to get the very best out of them. And we have 3 elements to the way we operate. So we have a compliance role. This is, so everything that we put out into contract, we make sure is being delivered. So that absolutely, that compliance, making sure we're getting value for money, the right outcomes, is a huge part of what that team does. But what it also does is develop and support the market. And this is absolutely key. And there's a really focus on this from the CQC assessment, picking up from Martin's previous point. So we introduced a programme back in 2018 called Maximising Support, Minimising Risk. So it was more about being proactive rather than reactive. So what we were doing, we were working with the market to ensure, for example, that when CQC came over their threshold, they were inspection ready. And we saw the real benefits in that. So in 2020, 2 years in operation of that programme, we were above the national average in terms of homes being rated as good. I'm going to come on to this later in the presentation. Through COVID years, we've got a slump in there as well. And I'll talk about more how we're doing about that. But working with the market to continuously develop and improve itself is a real key element of this team. And that's important because it's about the future. It's not about standing still. And also, this is a particular area at the moment, so things like dementia, going on to the previous conversations, we need to develop more and more services that can support that area of need. But also mental health is another area where we're working with the markets to develop and have services in place, so they're there to be able to support those people that we serve. So it's not just about compliance, it's supporting them. But then we also have an intervention. We have 2 people in our team that manage intervention. So where homes do get, or providers of services do get into difficulties, whether that's financial difficulties, whether we've got serious concerns around quality, there's been a safeguarding that's of significance, then we have these 2 members of the team who again primarily work with them to turn around those services, and I'm pleased to say in the vast majority of cases they do turn around those services. So inadequate ratings, You won't see this data at the moment because there's a lag to it. It's normally around about 12 months for CQC. But we're starting to see providers who were inadequately rated are now coming out as good. However, there are some, and sometimes you might see my name appear in the media where we've had to intervene and decommission those services. And those are few and far between, but that's what that team's there to do, to ensure that we mitigate as much risk as possible from those service users who are experiencing those services. So that's just a bit of context to what the team do. Rachel's going to take you now through about our approach to contract management, our guiding principles, how we operate.
Thanks, Alina. Next one, please. Thanks, Jess. Okay, so this is visual reputation that I'll talk to the committee around really the key fundamental building blocks of our approach to contract management. As Alina said, it's about supporting commission providers to deliver those effective services that we commission for them, and also to develop that provider market through the liaison and through the engagement that we have with our key providers, many of those key strategic partners. So I want to start with talking about the values-based working, and I want to pick out a couple of those key values that really underpin our approach. Relationship-focused, I must say, is the core of what we do. It leads to, from some of the comments that colleagues have already mentioned, we base our relationships, they are the crux of how we work with our providers. Without those relationships, we wouldn't be able to achieve some of the things that we absolutely do achieve with partners. And I think you're right, when we get the contract out, we know we've come to a point where we've got that relationship wrong, or we need to really reaffirm where that relationship needs to be. So we really work to make sure that those relationships with our partners and our providers are absolutely transparent and open working relationships. We value that transparency. If a provider's got a problem, we've got a problem. It's very much a partnership way of working to make sure that those services deliver for residents. I think in one of the appendices for this, there's some feedback from our providers that they really value the approach that we take in terms of that relationship focus. Another key value that links to the other one of the pillars of our approach is about valuing partnerships. We literally couldn't do our job without partners. We need our partners to really help us inform of the other key pillars of our intelligence approach. So a lot of our working with our key partners and the vast list of those, I think is listed in section 6, around all the key partners that we work in to deliver our approach in terms of supporting providers. And some of those will be joint visits with partners to actually working collaboratively with them, with partners and with those providers. Another value I wanted to just point out was around the team is very much driven by those positive outcomes for individuals. There's a really clear line of sight to the end user of the services that we support, and part of that is how we bring the service user voice through our contract management to make sure that they are part of hearing how those services are working and being delivered. And then finally, continuous improvement. You'll see that later when we talk about our initiative around thematic learning, but we really do expect continuous improvement from our providers. We know that the market is always moving, legislation's changing, initiatives are coming up. We need our providers to be in that understanding that movement forward is the only way they will progress within the market. They need to be having that up-to-date intelligence that we and other partners share with them. But that's also the same approach within our team, making sure that we're always reviewing our processes and how we are working with partners and how we are working with providers to make sure that that is delivering for the outcomes that we need for residents. So the values very much underpin how we work. In the centre, you'll see description of our tools. Like Lina said, I could talk to you all day about the different ways that we work and engage with providers, but I just wanted to pick out a couple. We have a suite of really robust contract management frameworks, and each of those is developed for the different types of services that Alina alluded to, so residential, community-based, strategic. Each of those has their own framework which sets out really clearly the expectations of how we want to work with providers. We're very transparent in the way that we work with them in terms of those visits. They know exactly what we're coming to look at and want to discuss with them. And those frameworks really provide that consistency of approach across those individual providers, so we can really understand how are those services being delivered, what concerns may be arising, and what support we may need to give them to ensure that they're meeting the outcomes of the contract. Each of the contracts that we mentioned have a dedicated point of contact, so they have a dedicated officer that they can come to for those day-to-day queries, and in turn those officers liaise with the partners that I alluded to. In terms of the frequency of engagement, that's very much dictated by the framework, but also by the risk approach, which I'll come on to. So the frequency and engagement for some providers, as Alina alluded to, if an intervention, can be daily when we are dealing with those types of need. But for other services, it will be dependent on what their risk status is, but also what intelligence we have that's coming through. So the main tool we use in terms of determining risk and helping us with that intelligence piece is our risk matrices. These are really dynamic and developed live tools that pull in intelligence from a variety of sources to help us really understand what is going on in this particular service. Where are some of the barometers that might indicate that we need to go and dig a little bit deeper, or understand where those themes might be coming through? So some of those intelligence sources are ones that we've discussed this morning. So safeguarding alerts that come through, or incidents that might be raised, or intelligence that might come from third parties, or poor practice concerns that might be raised by practitioners and colleagues in adult care. Those intelligence sources help us to understand where the balance of risk in terms of intel is and indicating that we need to go and increase our contract management approach, or engage with that provider to really understand what's happening from those tools that really help us understand where we need to focus and prioritise our activity and interventions. So that's a really key tool that is absolutely part of that key message there. Also, as I've just alluded to, your partnerships and your intelligence sources absolutely critical to the way that we work. They help us feed into those tools, but then, as you can see at the top, they also help us understand when that intervention, when that risk-based approach, and when we might need to escalate from our normal business as usual engagement with providers to something that's much more intensive. If we can go to the next slide, please, Jess, thank you. So this gives you an oversight, high level of our escalating concerns and how we manage those. So this is when concerns or risks may require more intensive support, may require the intervention team that Alina alluded to, where you have those specialist officers that go in. I think within the report you've got some examples of when we have used those officers to turn around providers. One particular example that went from inadequate to good by the very intensive work that went into that provider to prevent that turning into a loss of provider and requiring the residents that live there to needing to find alternative places to live. So that intervention really does make a difference to the residents that are living in those care settings specifically. Other activities that we use, peer support is really, really important in the team, and that can be proactive peer support within our team, or sometimes can involve partners that can come and help us assess. Second pair of eyes, you know, understanding what we all see to make sure that we're all finding any challenges that we need, or we need to bring in the expertise of others to support a provider effectively. We have improvement planning process where we do identify where there's a challenge or a performance issue or a risk playing out, so that we work really, really closely to make sure that we can move a provider from a position where we have got those concerns and risks playing out to a lower risk position where that assurance level is improved. But obviously we do have those formal mechanisms, as you can see in the contract, should that not progress, where we do have opportunities to issue formal mechanisms against the contract, like defaults or like suspending placements in providers in very extreme consequences, or supporting a provider to actually exit the market if those concerns are at that degree. And we've got a really robust process as to how we do that in a collective way with partners to, again, mitigate the impact that that has on the residents that are living in those settings. So if we can move on to the next slide, please, Jess, thank you. So in terms of that oversight and risk picture that I just described, that really feeds into the oversight and the governance processes and places that we have to be able to escalate some of those areas where we are experiencing those challenges above and beyond the business as usual managing of those providers' relationships and delivery. So in section 8 of the paper, it talks about the particular ways that we do that. And just to highlight on here, so some of those internal and external governance structures and places where we're able to provide that assurance and oversight of the outputs of some of the work of the team. Internally, we have the Contract Management Governance Board, which is an internal board that sits weekly, where every week we look at the high risk that's playing out, we look at those risk matrices, we look at the intelligence that's coming in to guide where we need to use the team to be able to assess and intervene where needed. We also have the regular updates to divisional meetings, regular briefings with portfolio holders, and the themes that come through from our contract management get fed through to boards like the Clinical Governance Board and the Quality and Safeguarding Board. So what we're learning through our contract management and things that we're picking up and things that are impacting on the market can be brought through to those boards to feed through some of that intelligence and themes. And then we have external multi-agency arrangements where we go and make sure that we're engaging with those partners. The one I'd flag and highlight is our Service Quality Review Board. It's a multi-agency risk-based assessment board where we come together and we look at the highest quality risks playing out in the market every month and agree a collective approach to how are we going to address and manage and mitigate some of those risks. And some of those joint visits that I described with partners are often coming out of those agreements as to how we want to work best to manage those highest of risk providers. And that's every month we do that with our core partners. CQC is around that table, health is around that table, our safeguarding colleagues, adult care. It really is a very broad group of key interested parties that come together to look at that on a risk approach every month. Last one, thank you, Jess, from me. So this is, I talked about continuous improvement and our drive as a team. This is a core example of that, is this establishment of our thematic learning approach. I think this is acknowledging that the learning that comes from our contract management activity day in, day out is generating a lot of learning from how we work, but also feedback from best practice from partners and from providers and colleagues that we work with. And this is really about how we want to formalise and capturing that best practice and the learning that's coming from these engagements literally day in, day out, to reframe the work of our team and hopefully to work with partners to understand how we can do that through that learning lens so that we're not losing any of that intelligence and the learning, and it's the so what. So we do all this work with providers. We learn all about some of the things that are working well, some of the things that may have been challenging in one pocket of the provider market. How do we make sure that is shared across providers and across partners so that all the learning that we are generating by this approach is really used to make a difference? Because if we're not making a difference by the way that we're working, we're doing something wrong. So this is our sort of approach to continuous improvement of the way that we're working in contract management to make sure that, you know, we are driving that effective provider market and we are supporting our commission providers who do a really good job on behalf of this council and our residents. Over to you, Lena.
And to just join up then, so where we, so when CQC came in October, and I can recall from members real concern about the frequency of their visits. As Martin said, CQC are the regulators. They're ensuring that providers are complying with legislation. But the oversight of that market and compliance, ensuring that the right outcomes are being delivered, sits with ourselves. So please take assurance. It does matter, you know, in the sense that if they only go every 5 years, which I'll come on to explain to you why, but actually what really matters is that the council has these processes in place to have oversight of that market. If I can move now to the state of care. So the main purpose of CQC's presentation in October, I recall there being 5 themes that this committee were particularly concerned with. Overall ratings, if you recall, they went through that aspect, workforce, sustainability, care home availability, and NHS pressures. And what I've done is picked out what the state of care said nationally, and that is on the bit highlighted in green on the left is what we've summarised from the state of care, and on the right hand side is our narrative in Lincolnshire. Now, I alluded to at the start of this presentation that we were above the national average in terms of care homes being rated as good. We've seen since 2020, and Lincolnshire wasn't on its own in this, but we did see a drop in homes being rated as good. And unfortunately, as it currently stands, we are 3% below the England average. And in terms of being totally transparent, we're also below our comparative authorities as well. However, since this point last year, we have made an improvement. We've gone from the 79% to 80%. And what we've also done is we've now put back into place that programme, maximising support, minimising risk, and there's a real clear focus on the team in this area. What's important to note, though, is last year there was only 15% of our market who were inspected. So we believe that 80% is higher than that, and that's based on our assessment of the marketplace. But CQC have only inspected 15%. So those providers who are inadequate or it mainly requires improvement, they haven't been given the opportunity to demonstrate good because they've not been inspected. That's a real barrier for us in this data. Nonetheless, we're not sitting on our laurels. We've reinforced that programme again around trying to support the market to improve. Next slide, please. So we touched on this earlier today in terms of workforce. We're slightly different to the rest of the country on this because in the state of care, there were significant concerns raised around the workforce challenges. You know, I can't undersell really how significant that is. It might be the biggest workforce, but the turnover of staff in this space is quite significant. But in Lincolnshire, we've seen a step change over the last year. And as I alluded to, we've seen the numbers of care workers increase. And we've seen an overall reduction, as I said earlier today, in staff vacancies by 7%. And that really bucks the trend compared to the country. However, I do want to acknowledge that, you know, there are still widespread issues in workforce. It's a very, very difficult space. But as adult care and community wellbeing continue to focus on this as a key part of its work and investment, so we've put a number of initiatives in place. Currently, at the moment, we've commissioned some external work to work with an independent third party to see how we can reduce the reliance on agency use. So this is a real focus for the Directorate as we move forward. So sustainability, so the next slide, please. We're in a similar position to what was painted in the state of care. And that's largely borne out through the workforce issues that I referred to, but also the running costs in terms of running some of these businesses. So we have seen a slight reduction in the number of residential care homes from 291 to 287. It should be noted, though, what we are seeing, which is very similar to the national picture. We have seen 4 homes come into Lincolnshire, the bigger homes, where they've got over 55 beds. That's something that we are closely monitoring and got a link in with the district councils in that respect. And obviously the casualty of that, which was played out in the state of care, and it's been reinforced in Lincolnshire, it's the smaller homes, so those with less than 30 beds. We've seen those being affected by this change. This is all underpinned. We have something called a market sustainability plan. You may recall last year myself and Pam came in to talk about what that plan looks like. There is no plan B in social care. The vast majority of what it commissions is externally. They've got a small in-house day service. So the market being sustainable is one of their key priorities. It's on their risk register. They're very reliant on this market. So the makeup of that market is equally important. There has been an increase in domiciliary care agencies, but in the case for Lincolnshire, you'll be aware that we only commission from 9. We have a lead provider model. However, some of those agencies do work with those lead provider models, so we do have some oversight in that market too. Next slide, please. In part, this is our Lincolnshire's position is similar to that of the national picture. Martin alluded to this earlier this morning. We are in a strong position in terms of availability of care home beds. That differs across the county. So, for example, if you're in the east part of the county, there's an oversupply of beds. In the west, there are pockets of where it's difficult to get beds. In the south of the county, it's a very mixed picture, okay? But overall, there's an occupancy rate of around about 15%. A healthy position is more 10 to 15%, so that is something, forms part of our sustainability plan. It's really important that we actually look at that. So really strong position around the occupancy. We have seen, although we've seen a reduction in the number of care homes, there's been a slight increase, 1.6, and we've compared it to the same point when CQC took their data, which is stated in the report. There's been an increase of 1.6% in the number of beds. And again, very similar to across the country, although we've had a greater increase, the number of people living in care homes is increased by 7% in this county. And we've also seen an increase of 10% in terms of self-funding markets. As I alluded to, the overall average is around a 15% for the occupancy. So in part, very similar to the national picture, but there are some differences. And the last slide, please. This is a slide we're really proud of, adult social care and community wellbeing. Yes, we heard Councillor Bowkett say at the start of the morning that, you know, that NHS system has been under increased pressure recently with the junior doctor strike. But in actual fact, we've got a number of processes in Lincolnshire that do make us look a little bit different to the rest of the country. So we've really invested in our patient flow in terms of the joint arrangements that we've got in place. And largely those really fall around two services. We have a reablement service, so that's offered in people's on home. And on average, that provider, 99% of referrals have been accepted. And so that is maintained flow through the hospital. There are very, very little delays in hospital as a result of being able to, our reablement service, able to pick up people fairly quickly. And really importantly, in terms of that reablement service, the outcomes are really positive. Many service users go on to receive no onward service. And that's equally mirrored in terms of the active recovery base. So this is a residential-based service, but that kind of wrap-around reablement, therapeutic support goes into a setting. And again, that's really supported our NHS system over these winter periods. There isn't many times you're hearing, and I'm probably going to regret actually saying this, but you know, you're not hearing regularly now that our system is going on to critical alert as a result. And largely, reablement and active recovery have played a really big part in that. And again, you know, really, really good outcomes are coming out from those beds in terms of a clear reduction in ongoing care needs. And finally, home care. We've seen a 67% reduction in the number of individuals waiting in hospital for care homes. And that's coupled in part because of the support we've got with reablement and the active recovery, and they work really, really closely with our home care providers. So I think we have a strong offer, and that's really been borne out in the last 12 months. So those are just the 5 areas that you showed particular interest in relation to the state of care. That is what it looks like in terms of Lincolnshire. And my final point really, and it really links into the point that Martin was saying around the CQC assessment, what that played out in terms of the assessment of Lincolnshire. So we had a strong oversight of the market, our processes were sound, exceptional processes around the management of risk, and our governance is strong. The working relationship with providers is extremely strong. In fact, The inspector said to us we couldn't find a single provider to say a negative comment. But really importantly, we have the balance right in managing that relationship with the providers. So at the forefront, goes back to the point Rachel said, the forefront, so we know what good looks like and we hold providers to account. But in that we have mutual respect. Thank you.
Thank you. Cheers. Well, that's a very thorough, comprehensive report and outlines some very good work, without a doubt, and the fact that CQC and it is a flagship. I mean, let's not get it wrong. It's a very good management service of the contracts and everything else, and many councils and public health authorities would benefit from our expertise. We have got a number of beds there, 15%, that are sort of in effect empty. Is there a way, and the fact that the active recovery beds has been so successful, is there a way that we can sort of create like another tier of sort of nearly like a booking.com sort of approach, where if we need it, we could have a more lightweight touch contract for those to help, because some of those under 30 beds or under will be the ones that are vulnerable, that can't often get the extra capacity that they need, and at times we could do with that capacity, but not through such a formal arrangement, but would be a sort of a step sort of to progress, having seen all the research and figures.
Yep, okay. So this goes back to the point around working with the market, developing that market. So for example, in some of these services, it's really, so mental health, for example, we want to engage with the market for them to diversify into services where we feel where we're moving, our direction of travel. So I think it's fair to say that the more we transform those services around community-based services, the less reliant we are going to be on care home settings. And so it's working with that market to shape what we want for the future. So that's why what we don't want is to lose that capacity. We don't want to lose that workforce out of the market. So we see that very much as a collective of working with colleagues across adult care and community wellbeing to work with the market to shape what the future looks like. It is inevitable we will see changes in this space. You know, as I've said, in the last 12 months, the offer around hospital flow is very, very different. So you have less discharges into care homes that you once did. So it will inevitably change. What we want to do is to work with the market so we've got the right services in the right place at the right time. But that is absolutely fundamental. And I think there's an acceptance within the care home market. It's not sustainable for us to continue to commission from 300 homes. That's just not sustainable given the models of care that we're moving to. But they're a partner, and a really valued partner, that can really offer value in this space.
And nor do we want to go back to running our own care homes like in the past. So there is a balancing act. I think just on sort of what we've spoken about in the previous agenda items of the sort of the whole community-based asset, I mean, an area for me is how can we strengthen the sort of the hub dash community-based asset, like that Centre for in Nunsthorpe, but that sort of, you know, we commission out. Can we start to sort of, in effect, herd into certain locations so that rather than if we commission, to say, somebody out there, they go and find their office space somewhere that might not be really ideally suited, but they find their office space and deliver the services. And sometimes I think we need to start to shape it a bit more where they rent from us off our estate where everybody else is, and in effect we sort of you get that community hub and all the sort of community facilities and services that we offer starting to sort of centralise them more so that you can get a bus and everybody heads in. I mean, I know the previous contract talked about walking within 15 minutes. You can't walk anywhere in 15 minutes. For a walk from here to Tritton Road, it'll take 15 minutes. And then when I go and buy what I want to buy, I've got to hug it all the way back. It just, no one really works on that model anymore. It's how can I drive my car and get it parked as near as I can to a facility? Or if I'm going to use a bus, is it going to actually stop where I want it to? And I think we need to start to move in a sort of a slightly different direction, I would suspect, is the next plan of action.
There are elements of that kind of transformation starting to happen. So if I just a couple of examples. So domestic abuse. Domestic abuse, 3-4 years ago, you had different partners commissioning different types of services. We have a multi-commissioner approach in that space now, where monies are pulled together, services are developed as a single system, and that's a really, really good example of that. Intermediate care is something that within adult care and community wellbeing, we've got a real clear vision that those different types of services are brought together across the piece, both in terms of your hospital setting, your community setting, so you bring those hubs together as you've really described. So I do think we're on that journey with commissioners in terms of it comes back to Rachel's point. We talked, we really pride ourselves on our relationships with our provider market. That's the direction of travel, and there's some really good successes in terms of how that looks across partner agencies as well. Yeah. Because trying to do it alone, okay, we're not going to deliver that vision or within budget. So absolutely accept the point that you raise.
Yeah, because I mean the wellbeing hit on that in effect. When we're going for a 10-year contract, we don't really know what the future is always predicting, and we've ended up scrapping some of that contract because it really wasn't used and wasn't great value for money. And in a sense, it's how do we make sure that our contracts stay viable for modern day, rather than sort of, and in some sense making sure that we're not doing it from a point of view of tokenism, as in, right, we're ticking that box, but actually the fact it doesn't really deliver, but we'll just manage that contract.
I'm going to let Rachel come in here. The one point I want to say, no one contract, when we move to its next generation of that contract, very few now look the same, because it's that point that Rachel's saying about continuous improvement. And you're absolutely right to use that example of wellbeing. Wellbeing, its second generation of contract looks very different. We've learned a lot from that. The services have been shaped based on needs. So absolutely, we would see at every time when we get into that commissioning cycle, look into, particularly where it's a statutory service, we need to procure it out. Actually, there's about 9 months to 12 months work before that where we do a fundamental review. But you want to come in because you're at the heart of this.
Yeah, I think the key point here for me is around that expectation on providers to work in that way now. And that is written into contracts, that we expect them to work as collective strategic partners. And part of what we do in the contract management space is also make sure that those links between our strategic providers are strong and that they are effective and that they are working. So for example, in managing, let's say, the wellbeing service, I expect there to be very good working relationships between them and One New Lincolnshire and the carers service and the substance misuse service and the DA service. And as part of our contract approach, we'll be making sure that's happening by analysing the information that we're getting through to understand, are there cross-working, are there cross-referrals? So there's an absolute expectation for our strategic partners to work in that way. And I know you said about the collective hub, but actually them working in that partnership way where they have joint clinics. So I know that the housing related support contract and the substance misuse contract have dual workers that work together. So whilst it's not always a place-based working together, there is absolutely that cross-working across some of our key strategic partners, and we facilitate that through contract management and check it's happening, but it's also written into contracts as a very clear expectation that we don't want services working in isolation. There's an expectation that they work as a system as partners.
Yeah, I mean, just on that, I mean, that in some sense, we are a commissioning council, and the danger of a commissioning council is that we commissioned it sort of 15 years ago, and it rolls on, and in some sense, we change, but we're very slow to change, because in a sense, if you set the budget, say that thing there at 5 million, when it comes up for grabs, we're still in the bigger budget issue that we don't have spare cash. So technically it's 5 million again, and then it rolls over, and it's that sort of, we have to make sure we don't lose innovation by the fact that we really are a commissioning council. That gives us some scope for innovation, but it can also put the brakes on the way that we develop. On that note, I'll open it up. I've got Nikki, then Tracy.
Yeah, thank you for the report. It's robust, and you've answered our questions that we touched on last time. I remember that very well. So you've really gone through that very, very well for it, and I thank you for that. What I really wanted to touch on, and it's a comment actually, not a question, congratulations on that, for showing that and proving it, you know, and I'm pleased to see it. But also I think it's touched on the very fact that Derek was mentioning this morning, that if we need to stay ahead of it and how we're going to work with our partners and health providers, we've recognised that health in Lincolnshire, we've got to move forward. We've got to take a good look at what health in Lincolnshire now needs to be, because we've touched on the history of it. The National Health came from 1948, and it's now out of date. We all know it's out of date, and it's the elephant in the room. So we, as a county, we're looking at what's health going to look like now in Lincolnshire, and we've got to move forward with it, and that's the plan that we've asked for, and I think Hugo asked for that. So now we need to know how we're going to move forward with it. Let's start it. But also, are you able to, Martin, progress that nationally? Because we're good at leading. We've shown that we're good at leading, and we can do it, and we're successful. So based on that, nationally we have a problem with our health system. So it needs to change. My colleague Mark here has touched on that, and it's frustrating. We need to move forward with it. So we start obviously because we're Lincolnshire, we do Lincolnshire. But are you able to influence then that it has to change? We have to do it differently, because we've got to look at the county and look at how health is delivered, and not centralise it from a hospital, a doctor's surgery, hubs. You know, this is brilliant how that works across the county because of its rurality and the difficulties. I was at a meeting yesterday with Women's Rise. They know they're going to have to deliver that service away from the city. They've got to go to the place where they need to do it. So we've got to be very flexible. So that we move forward with it. We don't just sit going round and round with these reports. And Derek's report was brilliant. You want to do it. And I think Hugo's already said, let's do it. So I would like to see that move forward. But can you influence that? Thank you.
Yeah, I think you've summed that up very well, Nikki. And I think in some sense it would be good to see where the future starts to lie, sitting in with Derek in a few months' time, and actually look at the contracts and say, not individually, but on a bigger picture, where do we go, how do we want to go, and how do we perceive it to go? A bit of a future vision, start to map out. Martin?
Shall I pick up that issue of can we influence? So I'm sure you come across the Association of Directors of Adult Social Services, ADAS. That is our main means through which we do that. Every single local authority in the country, every single DAS in the country is a member of that organisation. It's essentially our professional body, and through that route we influence nationally. I'm actually one of the national trustees of ADAS, and I have the responsibility for the regions within ADAS, and therefore one of the things that I do personally is I chair a regular meeting of all of the chairs of the regional branches. And so we very much try, therefore, to get that sense of what's going on nationally and regionally. What are the good things that we can share and we can influence? The Department of Health and Social Care is very interested in what we think, which I have to say has not always been the case, but it is at the moment. And therefore, in fact, the Minister for Care, Helen Whately, meets with us on a regular basis. And in fact, we have a meeting coming up with her at the end of the month. And you know, it's quite something that we actually, as a group of chairs, will have 45 minutes with the Minister with a very sort of open and frank conversation with her. And what we've been particularly seeking to do is to influence nationally in two ways. One is to say, here are what we've been calling investable propositions. If you as the Minister are able to get hold of £40 million, £100 million, £300 million, this is what we think you should invest it in to make adult social care nationally a better service. And then the other aspect is to, and again this is picking up part of the conversation that we had earlier, resisting the Department of Health and Social Care's natural centralising approach, that there is a strong tendency in the department to take the view that, well, things need to be the same across the whole country, don't they? Because that's fair. And therefore we have national processes, national systems and national rules and national improvement processes and the like. And we as through the regions are saying, well, actually, the northeast region is very different from the southwest region, and rather than there being a single size model that fits all of us, have some confidence in us that we do actually know what we're doing. We are accountable politically through our local elected members, and allow us to have some variation locally, because I mean, I'm very conscious of it even within this region. Some of the things that I was doing in Leicester that were absolutely appropriate for the population of Leicester are not appropriate here in Lincolnshire. The population's different, the geography is different, and that we need to have that flexibility to do things differently. So we are having, as I say, face-to-face meetings, direct meetings with the Minister, with the most senior civil servants and other civil servants within the department, and those messages are very much getting across. And I should note that I always take care that when I'm involved in Teams meetings with both the Minister and officials from the department, I always have my Lincolnshire wallpaper up, so it's always very clear where I'm from. And I do believe that that has a positive impact on the reputation and the awareness of the county, that, you know, I am hopefully one of the leading DASs in the country. I hope, you know, the Minister knows who I am, and that she knows that I work for Lincolnshire, and I think that gives some added credibility to Lincolnshire. I think also the fact that I work for Lincolnshire gives some additional credibility for me, so it works both ways. But yes, we do influence nationally.
Good. Tracy?
Firstly, I'm really sorry, but I'm going to have to fly out of this meeting, so I'm going to watch my answer on the playback, if that's okay. So sorry about that. I've literally got to go. So actually, I'm always quick to ask questions, but actually I want to be quick to say well done to the contracts team, to be fair. I think they're excellent and experienced very differently across districts, as we touched on at the beginning of the conversation. I challenged the We Are With You on, I had a separate meeting with you guys, and the detail and the knowledge that you had, you know, that presentation was very good, but it wasn't just talk. I've seen the reality of it. So absolutely, and the passion that you spoke within it as well. So really great. I just want to throw something in there. Could we have done anything better on those care homes that you used on page 109 as an example that actually fell into needs attention or whatever? Could we have done something more to have picked them up? But I genuinely am going to have to watch this answer on the playback, so I really apologise for that, Chairman. Thank you.
Thank you. So I think one of the key things when we have those instances, particularly where we have providers like in the cases that are in the report, where we had a provider that was an inadequate provider, and we do that intensive support with intervention, we always do lessons learnt. So we always do that with partners and with our contracts team to understand that chronology of what happened and when. So if there was opportunities to intervene earlier or look at what intelligence, we will learn from those experiences, and some of the learning from past working with providers has helped shape the tools and processes that I've talked you through this morning. So that is part of that continuous improvement that we work through, to really look at what lessons we can learn as a service and as a team by the way that we work with providers when it's gone well, but also maybe when it's not gone so well. So we're very open to that approach in terms of really learning lessons when things haven't necessarily gone as well as we wanted or things have come in. But I think it's also fair to say that sometimes even with the best robust processes and risk matrices, there can be things that fly in left field that cannot be accounted for or cannot be predicted. And it's about how we then respond to those with providers and partners that makes the difference.
Thank you. I've got Mark.
Oh, sorry. Can I just add something to what Rachel said? One of the things we actually do is we meet with CQC on a monthly basis and we go through their top 10 and our top 10. Nearly month on month they match. So that gives a sense we're all looking at the same right things. Okay.
Yeah. Excellent. Mark? And then Mike.
Yeah, thanks, Mr. Chair. And yeah, again, just to reiterate what everybody else has said, it's a really good report and a very, very good presentation. Just one question I wanted to ask. I mean, obviously, you referred in the presentation to the fact that, you know, a decade or so ago, the model in Lincolnshire was broken. And now it's obviously a lot better than it was. But somebody's been around for probably about the last 8 or 9 years and on this committee, very much aware of the relationship we have with Lincoln. And I'm just wondering if you could sort of explain what part Lincoln obviously and having Lincoln has played in the process. Thank you.
Yeah, really good question. I mean, I was so close to inviting Melanie, who's the chair of Lincoln, or Chris, the deputy chair, to come along this morning. Not because, you know, they clearly have a voice, and, you know, I feel that the question you've asked, they would be able to answer that back perfectly. From my perspective, they've massively helped. So our relationship is really important with them. I can, if I go back, it must be 5 or 6 years ago, we went to a regional event and Melanie said to me afterwards, did you notice that all councils were sitting on a different table to their care associations, but Lincolnshire? The care association was sat with the officers from Lincolnshire, and it goes back to what we're saying about mutual respect and the relationship we have. I don't think there's a single week that goes past where myself or one of my managers is not having a difficult conversation with the executive of Lincoln. We've had one this week. We were talking about the rates that will come to scrutiny next month. But there's that mutual respect and understanding of each other's position. So it's vastly improved. That's what didn't exist 10 years ago, Councillor Whittington. In everything we do, we work hand in hand with them. So there is a no surprise culture. We have the very difficult conversations. We have the really hard negotiations. But also, where we experience some challenges in the market, I see they've really got an important voice to work with us. So many occasions, if we've got into an intervention, I can pick up the phone to say to Melanie, we need to deploy some care staff from the county to help us over the weekend in this home. And they're able to respond to that very quickly. Okay, so it does make a difference. And I think Lincoln's got one of the highest membership, and that's because they see the benefit of working with the council, you know, in a real positive, constructive relationship. As I say, we've got our different kind of lines, our negotiation positions, but they've made a huge difference. And as I say, I ummed and ahed asking them to come along because I see them a part of this picture, part of this puzzle. It was the time that stopped me preventing doing that. But yeah, really important role.
Excellent. Mike?
Thank you, Chairman. Thank you, ladies, for your report. I didn't realise you were dealing with 600 contracts. That was a bit of a surprise. I presume you sort of stagger those throughout the year or throughout the years, so you're not trying to handle too much at once. And I'd wondered whether when you do your contracts, do you put any financial penalties in there if somebody doesn't perform? And could you remind me, I think on the active recovery beds, are we now in the 60 bed ratio because we're in the winter period?
The 60 beds that are in place, yes, that's right.
That's right, okay.
Yeah, that's
Then
right.
you mentioned in the report that there were a number of vacancies in some care homes.
Yeah.
I was wondering whether you could work with the NHS, because we're told on the television and the radio and on the papers that we've got a backlog of people sitting in hospital beds. I wondered whether we could get the NHS to pay to move people into those beds that are able to move out of hospital, therefore creating the bed space. Thank you.
Thank you. If I work backwards from there, so I don't believe we've got huge amounts of people in the Lincolnshire system waiting to be discharged to get into care beds. And I think that we're in that position for the reasons I shared on that slide. We've got other types of services, active recovery, reablement and home care, that are able to support discharges with better outcomes, and that's our direction of travel. I will say that Health have invested into those services as well, because they recognise the benefits. You know, it was a real test case 12 months ago when we introduced active recovery. Their mantra is home first. This was a bed-based model. It goes against what their principles are, and we've really we've gone a full circle on that, because they absolutely really see the benefit of these active recovery. So I don't think we've got the same problems in our system as you see sometimes playing out in terms of external coverage. However, the principle you're saying is absolutely right. We need to do more of that. We need to work more with health. It's back to the conversation we had. We need to work much more as a collective system, not in the reactive space, the proactive space in how we commission, how we put those commercial arrangements in place to support the communities that we actually serve. So I reference intermediate care. That's a really good example of that. So health, they commission lots of different services. We do. What we need is a central hub. Okay, we've got a single process, one pathway in terms of discharge, and that hub have to their disposal services that have been commissioned as a single tier. So your point's right in that's what we need to do more, but I don't believe we have that issue in our system. Obviously that can change, depends on the number of discharges into hospital. Your point about the contracts, our space, adult social care, and we're doing more and more in that external space around multi-commissioner. So, the team have picked up the lead around domestic abuse. We're doing more and more for health. It is a very demanding space in terms of what we're commissioning, but yes, what we try to do is to stagger those so we don't have any bumps in the road. We're trying to commission too much out to the market, because what we need the market to respond to that as well, and we need to make sure that the market is able to respond. So it's in our interest to make sure we do absolutely stagger those. It can be challenging though, because if the government was to distribute additional funds, for example, that can put pressure on us to distribute those out in a legal way through the procurement regulations. Your other question around financial penalties, we do build those into the contract. With the right relationships, we should avoid these wherever possible though, because all you're doing is, if we're going to continually penalise and we don't see it as a collective issue, they will start to have issues around sustainability, and that's not in our interest. Remember, they are Plan B. We have no in-house service, but they are built in. They're built in really, really effectively. And Rachel and her team, do you want to say how you manage that?
Yeah, we designed those mechanisms to make sure that those penalties are attached to the right measures. So they're the measures that really impact on the delivery to service users. So where we would put those penalties, when we look at the designing the performance and the monitoring schedule for each of those contracts, we would determine which of those measures are the ones that really make the biggest impact, that we want to make sure that delivery is really effectively closely prioritised by providers. So it's also a hint to them as to which parts of the of their performance are most important to us as a commissioning authority that we want them to manage. So we robustly look at their data that comes through and their performance that they submit to us to understand where are they in terms of those penalties, are they close to them? But before we get to that, we should have implemented the process that I talked about earlier in terms of improvement plans before we even get close to that. But yes, those providers are aware of those, they're written into those contracts, but we're very careful where we place those so that they don't have perverse incentives for providers, that they're avoiding certain penalties that actually would detract from other service delivery, if that makes sense. So we have to be careful where they're placed so that they do affect them, delivering those outcomes that we want to achieve. But like Alina said, the ideal is that we never get into discussions about service credits, because services are delivering effectively and we've supported them before they get to a point where their performance is at that level.
Yeah.
Okay, all right, well, thank you very much for that. I think just really sort of going forward, where in terms of this sort of mapping out the future, and in effect we've talked about the previous paper, we've talked about hubs. Is there a sort of like a piece of work where you can sort of just look and sort of, as in like anticipation rather than formally, because we're not at that zone, but i.e. what services could go into a hub in the future on a contract? What other health services could marry up into a hub, a community base, or, just sort of start to build something that we could just sort of see as a sort of aspiration to where we want to travel? And in terms of Derek's going to come back with his bit on the sort of future, and I think it's quite good to have future. If we don't talk about the future, we're never going to solve the future. We'll be in it with the same headaches. Can we do something like that? Coming back in about with Derek's, maybe just have a bit of a looking at the sort of community base, sort of hub dash, see where benefits can be done with some of the contracts. I mean, you've listed all the providers on that in the report, which is
we'll take that away. I mean, this is much wider than public health. The link with the other two commissioners, particularly.
And I know we've got the integrated health.
That agenda around health's really, really important. But in terms of direction of travel, we have adult frailty, specialist services we've particularly got a focus on at the moment in terms of trying to increase capacity in this county rather than being so reliant outside of the county. So we've got a work programme in place with Justin at the moment in terms of, and that in essence is again about bringing infrastructures together rather than doing standalone arrangements. But it's the same with adult frailty, and I've already said intermediate care twice. That, for me, really, really will change the landscape, particularly with our NHS. But also we need to build on some of the building blocks that we've already got in place. So it goes back to Councillor Clark's point around working with our health much more closely in LCHS, for example, in that community-based offer, rather than doing things separately. How can we come together to build that kind of community asset?
And that's in effect where I come from, because I walk round and I can see health standing alone. There's another place just out here, then they'll have somewhere else, and then we do something somewhere else. And this is my thing. That we end up being local but completely disjointed. What we don't do is bounce off each other, i.e. if you've got a load of people going into one centre, before you know it, you've got someone else sets something else up, a leader. It all sort of self-fuels itself to a better world. So you're not getting social isolation. More people get sucked in, and you get your volunteers, and it's all encouraging rather than we're local but we're fragmented.
Yeah.
And that's where I think we are now.
Yeah.
We're still isolated in terms of health and us, and we're fragmented. Everyone's going local, but local means they all going randomly in certain locations, and yet you can't catch a bus to any of them, and you can't walk because it's too far. But it might be still local, but it isn't local.
There are some exceptions. So, you know, the space around, it looks very different around that domestic abuse table now with the police commissioner.
You can't have them all coming into the same place.
We've got an integrated service with learning disabilities, so we've got a single commissioner. So there are some examples, but I accept the point we need to build on that.
Yeah, no, I accept that. And nor do you want sort of perhaps drug addiction coming into where the general public are, and any form of, you know, support. Some needs to be isolated and some needs to be more joined up. I'll leave that one for you both to have a mull through on what's the best way to come back. Yeah?
Can I just add to that a little? I think the point that we're making, what we're looking for is to be more forward-looking, isn't it? I think that's where you're coming from, to try and do that horizon scanning and seeing what changes are on the way.
Yeah.
And I think that's probably what you're picking up there. And it isn't necessarily, we're thinking structures, you're thinking making sure the service goes where it should be. But I have to admit, local people will still be thinking, where's my local service? And, you know, and how am I going to get there?
And a lot is...
This is the dilemma. But forward-looking and horizon scanning would be a really useful idea. Thank you.
And that's what we're basically I think that's the way that we view it. But that will also be what's being already worked on, hopefully for the ICB, etc. So it's just sort of bringing it through in respect. And also, I think we have a duty that we're councillors, that we take the message back to our communities, you know, and if you're going to create reform and change, somebody's got to speak the narrative and sell it, because that's what generally health and adults don't do well, is sell change, because it's everybody wants it on their doorstep. Okay, thank you very much. We'll go quickly then to Simon, but thank you Alina and Rachel for that, and that was very good. I know we've gone on a bit, but I think it was nice to give it a full thrashing through and airing and discussion, rather than just whip through because we're short of time. So thank you for that. Simon, you
okay, thank you, Chairman. The items for the next and forthcoming meetings are set out on page 127. As a result of some of the discussions this morning, there will be items added to April, June and July agenda. For example, at the April meeting, I think one of the suggestions has been, not from this meeting, but elsewhere, that there will be a review of the intermediate care, a review of performance sort of activity over the winter. But I won't go through all the items that I've added in, just because I've got a list here and I'll liaise with officers on programming them in. Thank you, Chairman.
Make July's meeting more that forward focusing, because if we talked about some of the services in terms of transformation and Derek's thing, that might be a good month to bring it all back. It gives everybody 6 months work through, and some of the other ones can go in June, then the likes of transition. Does that sound a fair reflection? Okay. Well, thank you all, and sorry for all going on a bit long, but I think we've had some very good, interesting debates today, and been well worthwhile. Thank you.